Good evening, everyone. We welcome you all to today's webinar on simplifying the complexities of male infertility. And it's an honor to have so many great speakers with us to solve the most important topic for the days in the infertility practice, that is simplifying the complexity of male infertility. In today's era where we know that advances have been made in the field of infertility, we all now know that male infertility leads to approximately 40% of the causes of infertility. So it's not just the woman who is supposed to be treated, it's both the women as well as the male. And today's topic is the most important so that we all understand what are the complexities or what are the problems we face when we are diagnosing or when we are planning to treat this male infertility. So let us start with today's webinar. We thank everyone. We thank all the audience who are logged with us for today's webinar. I would like to start by introducing Dr. Archana Baser. So Dr. Archana Baser, we all know, she is the Vice President FOGSI 2020. She actually doesn't need any introduction as of now. And she's also the Organizing Secretary of AICOG 2021 Indore. In fact, we are very lucky today we have the dynamic trio of 3 Bs of Indore, Dr. FOGSI ma'am, Dr. Baser ma'am and Dr. Kavita Bapat. She is also the fellow representative of AICC RCOG West Zone. She was the past chairperson of FOGSI Imaging Science Committee 2015 and 2017. She was the organizing secretary of ISAR 2016. I know her personally and we all know her that how dynamic she is and how vibrant she is in getting all of us together, and she has always been the lady with the smile. For me, she is someone whom I can always look up to, and she's always a phone call or a message away. So she needs no introduction, and we have Dr. Archana Baser with us today. Can we have the next slide, please? Dr. T. Ramani Devi ma'am, she also needs no introduction at all. She is the National Vice President FOGSI 2020, Managing Director of Ramakrishna Medical Center LLP and Janani Trichy Fertility Center. She has got 10 gold medals to her credit during her UG and PG, winner of the Professor C.S. Dawn Prize. She also received the prestigious award of Dr. APJ Abdul Kalam Award in 2016. She has got the Best Women Doctor Award by Tamil Nadu State. She has also been the recipient of Dr. Durusha Distinguished Community Service Award for the year 2020. And of course, she is the Vice President FOGSI 2020. I hand over the podium now to Dr. Baser ma'am to start with the auspicious ceremony of starting with the webinar today. Thank you.
Thank you, Kalyani, for very nice, kind words. It's always a pleasure to have you on the podium with us. Let me tell you a little bit about Kalyani. She's a very dynamic young infertility expert of Indore, and she is right now working with Nova IVF, and she has been trained in Mumbai and Germany, and she has more than 10 years of experience, and her expertise is in all techniques of reproduction, and she has done more than 1,000 oocyte and embryo transfer, but she is a very pleasant person, and always I can bank upon her to carry forward any program. So, I welcome you all to this forum of simplifying the problems of male infertility. I'm really thankful to all the panelists and all the speakers and chairpersons who have really agreed to come on this working day and have decided to spend afternoon with us. Why this topic of male infertility was chosen, I think all the vice presidents of my term, we were discussing that we should have a series of webinars where the topics which requires really more focus needs to be taken up. And the instrumental in this was my colleague and co-VP, Dr. T. Ramani Devi. And she said, why don't you take male infertility? Because male infertility is a topic, still people are treating women more than men. So we really need to focus on that. And I'm so lucky that I could, when I spoke and everybody said yes, and I have a really, really good collection of speakers who are here and who are expert in male infertility treatment. And we are looking forward for a good afternoon where we will be really enriched by their immense experience. So welcome all the participants and welcome all the people on the podium. And I would like, to thank Dr. Jayanta for really making it very smooth for all of us to log in this time. Before I really start the session, we are going to have little word of wisdom from our president, Dr. Alpesh Gandhi. But recently I just got a message from him that he is not going to be joining us, in time. He might be a little late. But few words about Alpesh Gandhi. He is a president of FOGSI. He leads from the front. In spite of all the storms, he remained calm and he led us. He involved us in different academic activities and CSR activities and kept the FOGSI going. He is involved in so many government organizations making the policies, and he was invited by PMO for contributing significantly during the COVID time to make the GCPR and all. So Dr. Alpesh Gandhi, a man with the vision, is our president, and we are really happy to be in his team as vice president. So now I hand over, since Dr. Alpesh has not been here, I don't know whether Dr. Mandakini has joined, Dr. Ramani to introduce Mandakini, and then we can take forward our...
I'm here.
Oh, yes.
Good evening, madam. It's my pleasure. It's my pleasure to welcome Dr. Mandakini Meg, who is the current chairperson of ICOG FOGSI. I think ICOG is doing such wonders even in this COVID period under her leadership. She is a very, very dynamic person, and she's been an international vice president, MWIA of Central Asia, vice president of AMWI Central Council, and she is a chairperson of AMOX, national vice president of FOGSI between 2012 and 13, managing committee member, and deputy director of health services GOM in charge of family welfare, and advisor to officer on special day family welfare GOM health department and Mantralaya, Mumbai. Prestigious post of superintendent of Kama and Albus Hospital for Women and Children in Mumbai from 91 to 95, maternal health consultant for Government of Maharashtra and UNICEF, awarded so many awards. To say a few, D.K. Datta Best Publication Award in Category A for the Best Book in FOGSI publication on recent advances in postpartum care, awarded D.K. Datta Best Publication Award again in B category, Best Textbook on FOGSI publication, Playing by the Rules, and Dr. Ganetra Award of MOX for Community Services in OBGYN, recipient of Mahila Gaurav Purashkar of Government of Maharashtra, recipient of Shailaja Pandit Award for working on women empowerment, domestic violence, contraception and family welfare, and invited faculty in so many national and international conferences, seminars, workshops, and world conferences. More than anything, she is such a lovely person and a human being who always encourages all the youngsters and the ICOG members to bring about their efforts so that it will be fruitful to all the people. And to say that we are now having under her leadership, training program have increased so much, and really the young gynecologists and the students are being benefited. Welcome, Mandakini madam.
Yeah. Good evening, everyone. Ramani, thank you very much for those lovely, lovely words. And all my own people are seeing here. I was so pleased when Archana told me, Madam, you are to, she actually called me Didi because I am her elder sister from Indore Medical College. All my Indore people, Asha Bakshi, Kavita Bapat, they call me Didi. So I am Didi, not Mamta Didi, but real Didi for them. So thank you very much. First of all, I like to congratulate actually all the organizer, Archana Base, Kalyani, and everyone. That thinking of male factor in infertility is so important. Around 15% of infertile couple, around 30 to 40% is the male factor, which is always overlooked. So Ramani has suggested really very well that we should focus on this one factors, as I am doing in my reproductive medicine classes. Ramani is a faculty, Archana is a faculty. You know, all of you have seen that forum, academic forum, and it has been so successful that we want to really repeat all these in the next batch also. And fortunately, I want to inform everyone that today we are having after culmination of 3 months, regular courses daily evening. Now today is the online exam. First time FOGSI, ICOG is having the online exam of the reproductive medicine, fetal medicine, and everybody. So I think it is a very big day for me also to declare here amongst all of you. And I can see Sonal Panchal, many of my friends, colleagues from ultrasound department. So thank you very much. I bring greetings. I just want to say 2-3 things about ICOG because many of you are ICOG fellows. ICOG, as Ramni has mentioned, that we are doing postgraduate, post-fellowship training. But what is most important is now in these days of election that you have to see the website. I urge you that you see the website because this time, first time the ICOG elections are going to be online. So it is my request as a chairperson so that maximum votes can be from your side and nobody should miss that. Second thing is information about the MRCOG. Archana is here, Asha is also here. That first time we are having the MRCOG exam also online and the link will be sent in the in this month to join the courses, those who want to join the MRCOG courses also. Third is very important again that all the certification course, I am so happy and proud that Archana will be conducting as a course coordinator our ultrasound course in OBGYN, and ICOG is doing lot of certification course for the FOGSI members and all our fellow members to enhance their knowledge and impart the training. That is also our aim. So I think with this information from the ICOG, I really from bottom of my heart that I thank Archana, Ramani, Kalyani and Asha, everybody, that you people are so good, so nice and so warm human being. And you call me every time, though the exam is going on the other side, I just join in to say best wishes and keep calling me. Thank you very much. Thanks a lot, Kalyani.
Thank you, ma'am. Thank you so much.
Thank you so much, ma'am. Let us start with today's webinar with our first session today. I would like to introduce our chairperson for today, Dr. Anita Singh ma'am. Anita Singh ma'am is the ex-professor of Patna Medical College. She is also the past president of Patna OBGY Society, vice president FOGSI 2020, chairperson of Endocrinological Committee FOGSI 2014 and 16, governing counseling member of ICOG 2015 and 2020, Chief Consultant JP Hospital Patna, and contributed many chapters in the book and of course many articles published in the National Journal. We welcome you, Anita ma'am. Next slide, please.
Shri Bali.
Thank you, ma'am. The next chairperson for today evening is Dr. Papat ma'am, but she will be able to join us later. Let us start with our topic. I think can everyone mute their mic, please?
30 ma'am.
Yeah, thank you so much. Let us start with today's session. It is a pleasure introducing the first speaker for the day. Can we have the next slide, please? Dr. Sonal Panchal ma'am. She is the one whose books we have been reading for so many years now. She is the consultant with Dr. Nagore Institute of Infertility and IVF. She is also the professor at Dubrovnik International University, faculty with the prestigious A.N. Donner School of Ultrasound, and also the master courses in Dubai. National Academic Director for the A.N. Donner School, India, pioneering research work in infertility and PCO-related ultrasound. She has presented various papers in the national as well as international conferences and journals, and contributed into several books. And of course, she is also the author of so many books. She is also a peer reviewer of the journal. So we welcome you, ma'am, today for our first topic of the day, the role of ultrasound in the male infertility.
Thank you very much, Kalyani, for those very kind words. And to start with today's topic, ultrasound in male infertility. I guess you can all see the screen. So we all know that, and we just discussed that about 50% of total patients presenting with infertility, 50% 50% of couples, the infertility is because of male factor totally or partially. That means male factor is really, really important. And semen analysis is still the most important parameter for the evaluation of male infertility. It is true that the criteria for normal semen have been changing from time to time, and the latest criteria published by WHO was in 2010, and this is what we follow now, which says that the total count of 15 million per ml with the total motility of 40% and progressive motility of 32%, and just 4% normal morphology can be considered sufficiently normal to give you a pregnancy. But what if semen analysis is abnormal? The first thing you do is you take the history of the patient and you examine the patient. Amongst the points in history, important is to find out whether the patient had any old viral infections like mumps, trauma to the testis, surgery or smoking is the history, and the occupational history is very important. There may be a lot of chemicals which do definitely affect the sperm counts, and not only that, even the temperature. So these are the two things which are important as far as, the occupational history is concerned. After that, the patient is examined, general parameters, the general health parameters are seen and they should be normal, and local examination of the scrotum and testis. But this is just a primary part of the entire thing. If these things are normal, even then you need to do a scrotal scan. If these are abnormal, even then you need to do a scrotal scan, of course, after the endocrine examination. So it is history, examination, endocrinology, chiefly FSH, LH, and testosterone. And ultimately, everything says, okay, go for a scrotal scan. If instead, not just abnormal, not just oligo or teratospermia, the patient has azoospermia, in that case also, we need to do a scrotal scan, but there, scrotal scan alone is not sufficient. You also need to do a transrectal scan. So basically, it is scrotal scan and transrectal scan which are absolutely required for assessment of a male patient with abnormal semen parameters. Erectile dysfunction I've purposefully not included here because this is most of the times being treated by an andrologist. It needs a penile Doppler on the ultrasound examination side, and it is a separate long topic by itself, so purposefully not included here. So then that means the scrotal ultrasound. What do we look into the testis, into the scrotal ultrasound? We have to look for the testis, we have to evaluate the testis for its size and echogenicity. We will also do the Doppler for the testis. We will check the epididymis for its ecotexture and size, and if it looks abnormal, we'll do the Doppler for that too. We also will look for hydrocele, so fluid in the sacral sac, scrotal sac, and we will also do Doppler to find out whether the patient is varicocele. So these are the primary things. Does not even take you 5 minutes to do the entire examination. What are the things that we'll look in the testis? The testis usually is a homogeneous echogenic ovoid structure. It is usually bilateral symmetrical, but slight change in size is often seen. But as long as the echogenicity is normal and the vascularity of both the testes are normal, it can be considered as normal, that asymmetry is not to be documented. The normal volume is between 12 to 15 ml, and it is important to check the mediastinum of the testis. This appears as a hyperechoic line which proceeds inside the testicular parenchyma from the capsule, and it is the lifeline of the testis. We must know that after the age of 40 years, the size of the testis gradually decreases. So like menopause, there is andropause too. The sperm density, the count, the total motile count, FSH and LH are usually normal when the testis volume and echogenicity are normal, but this is not a rule. On the other side, when the sperm count is low, it is very, very common to see that the testis is small, the volume may be small, the mean testicular length is small, the mean testicular width is small, and the depth is small. So all the three diameters, also called diameters, as well as the volume are all small when the count is small, and this is very common. Though the motility does not show a significant relation with the testicular size. In a small testis, the Leydig cell function is better preserved than the seminiferous tubular function. Coming to the vascularity, the testis usually is moderately vascularized. It is important that the resistance in these vessels is not very high. The RI usually is in the range of 0.5 to 0.56, but if it is more than 0.6, there is a close correlation with a low total motile sperm count, and this is suggestive of a poor testicular function. Coming to the epididymis, again, it has almost the same echogenicity as that of the testis, and we all know it is a comma-shaped structure with a head which is about a sort of a triangular or a cap-like shape. And if we move on to the posterolateral side of the testis, we will see the head, body, and the tail in the sagittal section. The total diameter is usually 10 to 12 millimeters. And thinking of abnormalities in the epididymis would be either absent epididymis, which leads to total azoospermia. There may be obstruction, which would lead to cystic lesions in the epididymis, or maybe inflammation, if it's acute, will show hypoechoic enlarged epididymis with a lot of vascularity. Let's look at some of the pictures of the same. We often see cystic lesions in the epididymis, and this is because of obstruction. That obstruction may be a result of a previous inflammation. So chronic inflammations, as we know, anywhere in the body would lead to fibrosis and obstruction. It is suspected when the normal ejaculate volume is seen, but there is oligospermia or azoospermia. Apart from those cystic lesions, you would also find tiny multiple cystic lesions and a very coarse appearance of the epididymis. This also is because of obstruction of the tubules, and as been mentioned earlier, it is quite common with infections. Hydrocele, free fluid in the scrotal sac, is quite a common finding, especially minimal to moderate, and this is not closely correlated with the infertility. So it is an incidental finding when you do a scrotal scan. Now so we have looked at the epididymis, we have looked at what generally we are going to look in the testis. Now coming to a detailed discussion about the testicular abnormalities that we see on ultrasound. And the commonest is a small testis, an atrophic testis. When the volume of one testis is less than 50% of the opposite, or the total of the volume of both the ovary, both the testes, is less than about 6 cc, that's when we say it's an atrophic testis. It may be totally homogeneous, or it may have an altered echogenicity. It is usually heterogeneous. It shows extremely low vascularity as compared to what we saw on a normal testicular picture. In these cases, in spite of a small testis, epididymis is absolutely normal, and the causes of atrophy are many. The common ones are inflammation, of course, chronic, especially ischemia, trauma, torsion, and undescended testis or cryptorchidism. Of course, there are systemic conditions also like cirrhosis, estrogen therapy, hypopituitary disorders, even local abnormality like large hydrocele may cause a compression and may lead to atrophy. And of course, aging we know is one important thing. And Klinefelter syndrome and a Y chromosome deletion. These two things we are not going to discuss here at all. Coming to the inflammation, which is the first one. Testicular infection is almost always associated with epididymis, like salpingitis is almost always associated with oophorytis. Testicular infection is almost always associated with epididymitis, and it leads to, in the acute phase, large hypoechoic testis and epididymis both. It is often heterogeneous as the infection, and depending on what the infection is, it may sometimes show patchy, well-defined hypoechoic areas, or sometimes just a heterogeneous echogenicity. Of course, it is important to remember that as the inflammation becomes chronic, the testis starts shrinking a little, the vascularity decreases, and the heterogeneity of the echogenicity moves more towards hyperechoic than towards the hypoechoic side. You may also see calcifications in the testis at times. If there is a hydrocele present with infection, it's usually a septated hydrocele. Looking at the Dopplers, both testis and epididymis will show increased vascularity in acute phase and decreased vascularity in the chronic stages. The testicular trauma is the second cause for the testicular atrophy, and of course it has a definite history. So it's not easy to miss that. But if you look at the ultrasound, it will clearly show tear, like, like testicular fracture. The same way like we see fractures in the bones, you see similar appearance on ultrasound in the testicular texture. And that is what is testicular trauma. This trauma in the long course leads to significant parenchymal damage and atrophy. Sometimes you may also see blood collections as hypoechoic spots, but we must all remember that whenever there is an acute hemorrhage, it appears hyperechoic, clotted blood appears hypoechoic. When the contusions heal, it may lead to cystic areas in the testis. The third important thing is testicular torsion. And we all know that it's much more common with the bell clippers deformity. Usually, very interestingly, the torsion occurs medially. There are therefore a lot of clinicians, when the patient comes with an acute history and on examination, they're very sure it's a torsion, they would detorse it without any other investigation on the lateral side, and most of the times the patients are relieved. But if it is a complete torsion, if it is a non-reversible torsion, it is not possible to do that. On ultrasound, just like we see in the ovarian torsion, we see a typical whirlpool sign. That is twisting of the pedicle, and because of, the pedicle contains vessels, so it is twisting of those vessels. Whirlpool sign is seen, which is better seen with the color Doppler. Apart from that, the vascularity initially is decreased, is not always absent, because only after the arterial blood flow is restricted, only then there is total absence of vascularity. Otherwise, it's only decrease in the vascularity. When there's a decrease in the vascularity, the arterial blood is coming, the venous blood is not drained, and therefore there's edema of the testis initially. Sometimes there may be infarction as a result of that torsion and cutting off of the blood supply, and that will result into typical triangular shaped hyperechoic areas. It is very important that if the patient comes with a history of torsion, don't make her, the typical history of severe pain, sudden pain, clinician says it's possibly a torsion, don't make that patient wait for a long time, make the diagnosis early. It's very important to correct it before 4 to 6 hours have passed on. Coming to undescended testis, which is again quite a common scenario, and we know that as the testis descends from the abdomen to the extra-abdominal location, it can get arrested at various sites, and the most common sites that we would find an undescended testis would be superficial inguinal pouch, maybe anterior abdominal wall, prepenile region, perineal region, and of course the femoral region. It has a bad impact on fertility because it leads to progressive damage to the germ cell, and it is seen in at least 15% of the patients with low count. What are your findings? On examination, there is empty scrotal sac. Even if you put a Doppler, put a probe, you will not see any testis at all. And then you ask the clinician, or if you are good at doing the scan, you will try to feel the entire path of the testicular descent and try to find out if there is any small nodular structure palpable. If that is it, that is supposed to be a undescended testis. And if that is seen, the diagnosis is very easy, because you put on the probe right there and you see a nice small hypoechoic, sometimes slightly hyperechoic, sometimes a small testis with calcified shell, or sometimes with calcification inside, and typically no mediastinum testis. So that is what you'll find that. But if it is not palpable, it is really a difficult task, and you have to trace the entire path from the scrotal sac to the inguinal canal to localize the testis. It may be sometimes, it may sometimes help to look at the femoral vessels and try to locate the testis just enteromedial and slightly superior to these vessels. Ultrasound is required not only for the location, it is also required to find out whether there are any neoplasms in it, because undescended testis, the neoplasms, especially malignant neoplasms, are very, very common. If it is not possible easily to palpate the testis, it is best to trace the spermatic cord if possible, and that you again locate it anterior, enteromedial to enterosuperior and medial to the femoral vessels, and it usually appears as multiple tiny anechoic structures because it's a vase and there are vessels. So all those vessels on the transverse section, they appear as anechoic areas, and that is the spermatic cord. So if you trace the spermatic cord down, it is possible that you may find out a testis which is not palpable, and that is the way to do it. But it is also important to look at the spermatic cord when the testis is not in the scrotum, because it may not always be just an undescended testis. It may be an ascended testis or a retractile testis. And in that case, you will see that the spermatic cord is not just a single loop, it is actually seen as a double loop, which tells you it is a testis which was descended but has now gone up again. So it is either retractile, I can bring it down, or it is an ascended testis as such. Sometimes the testis may also be in the opposite scrotal sac. So just like crossed ectopia of the kidneys, it may be crossed ectopia of the testis, and this is also an important diagnosis to make. Then coming to the testicular neoplasms, of course, they may be localized, they may be and well-defined, they may be more infiltrative. There's always a heterogeneity. It may show cystic areas, it may show hyperechoic areas, or sometimes even calcifications. If it is malignant, it does show a lot of vascularity, usually score 3-4 of vascularity, and it also leads to endocrinological abnormalities and therefore decreased spermatogenesis. Though I'm not going to discuss neoplasms too much. It may have it may be taken as a separate topic as such. Microlithiasis, this is quite a common finding, often incidental, patient not presenting with any symptoms at all, but yes, he may have oligospermia. There are multiple tiny hyperechoic spots seen in the entire testis like this, or maybe a few of them, and these patients with microlithiasis definitely have a higher risk of malignancy. Very important to remember that though it is called microlithiasis, though it is supposed to be calcium, there is no posterior shadowing like any other calcium deposit in the body with ultrasound. It is seen with cryptorchidism, it is seen with Klinefelters, with hypogonadism, with pseudohermaphroditism, and it's also seen with testicular atrophy, but it does cause abnormal spermatogenesis, and there's a pathophysiology to it, but we will not discuss that in detail. So it is important to document microlithiasis too. Then coming to varicocele, which is one of the commonest lesion found, And talking about varicocele, we all know that it is pathological dilatation of the pampiniform plexus veins in the spermatic cord, and it is quite a major cause for male infertility. It is important to diagnose because it is possible to correct this. It is possible to get a normal spermatogenesis after the treatment. Clinically, it is diagnosed by swelling, discomfort, pain in the scrotum after hours of standing. It has to be examined in the standing position. You may also do a Valsalva for that, and it is associated with hydrocellular opacity or cremasteric contractions and hernias also. On ultrasound, it is not very difficult to diagnose. If I directly go to gradings, grade 1 is where there is no dilated scrotal veins, and there is reflux in the spermatic cord veins up in the inguinal canal. But this is a subclinical. This is not important for us. It is usually not even diagnosed on ultrasound unless you go and do a scan in the inguinal canal. What are common ones? The common ones that we see are grade 2, when there is a reflux in the upper pole where there are no dilated veins on resting, but Valsalva would show dilated veins in the upper pole. Grade 3, which is where you see dilated veins up to the lower pole of the testis only on standing position, nothing on the resting condition, and you will see reflux on Valsalva. Grade 4 is where you see dilated veins at rest and dilated further with Valsalva or by standing up, and along with the reflux in them. And for grade 5, you usually have dilated veins with flow in it, even on resting, and you see reflux in these. Sometimes reflux is also present at rest, but you always see a reflux on Valsalva. Sometimes these veins may be thrombosed, and it is...
Excuse me, Sonal ma'am?
Yeah, I'll finish with this. I'll not take rectal. I know.
Ma'am, just last 3 minutes, ma'am.
Yeah, sure.
Thank you, ma'am.
Sometimes you may also find intratesticular varicocele. And it is important to correct this, especially when it is more than grade 3 according to this classification, and especially if the patient presents with abnormal semen parameters. If not important. Semen parameters normal, don't do anything. Then coming to the transrectal, and I'll quickly go through that. It is especially important for severe oligo or azoospermia with low semen volume. And it is just understanding quickly the anatomy of it. You can see the proposition here, and what you're seeing on the longitudinal scan is the urethra here, and which is entirely covered with the prostate. Prostate can be seen on sagittal section like that. It can be seen on the transverse, on the coronal section like that. And that is where you would see the completely homogeneous oval shaped structure. Just slightly superior to that, you are going to see 2 oval isoechoic structures, and these are seminal vesicles. These are the seminal vesicles as they are seen on the sagittal section, and any cystic lesions into the prostate in the seminal vesicles. In the seminal vesicles, and these are the vas deferens. So any cystic structures or dilatation of this suggest obstruction, and if there is obstruction, these are correctable. On the 3D with the coronal section, you can also see beautifully the ejaculatory ducts and find out any obstructions on that. You may find cystic lesions in the prostate, and these may be periurethral cysts. They may be sometimes Mullerian duct cysts. They may be a result of acute inflammations and ductal obstructions because of that. You can differentiate the cysts, and if they are present and if they are large enough to obstruct the ducts and lead to azoospermia or severe oligospermia, they can be corrected. We are going to listen a lot more about all these things in the panel discussion. These are a few pictures just for your knowledge about of the dilated tubules in the seminal vesicles. And these, as I told you, are signs of further obstruction and tells you about correctable lesions. So to conclude, ultrasound is important modality for evaluation of the male reproductive tract and can differentiate between abnormalities that would require surgical correction or those which can be treated by medical line of treatment, and they are of especially value when the semen parameters are abnormal. Thank you very much.
Thank you, Sonal. It was a really interesting talk.
Thank you. Thank you.
Thank you so much, Sonal ma'am, for the wonderful talk. And I'm really sorry to interrupt you in between.
Not at all, not at all, don't worry.
Just doing my duty, ma'am.
Yeah.
Okay, I would like to invite Anita ma'am to introduce Nagori sir for the next session, for the next.
It was an excellent talk by Dr. Sonal Panchal
Thanks,
on
ma'am.
ultrasound in male infertility, and your pictures were so nice and clear that anybody, like people like us who are not doing ultrasound for male infertility, are quite enchanted with the amount of information that you can get from doing a proper ultrasound, and almost you can make everything which is possible to diagnose by ultrasound, except the genetic and other causes. You can, any anatomical cause can be expected to be diagnosed by ultrasound by a person done like you. And I think you must be giving training for this also to the people who are coming to you for the training.
Thank you.
So that is very important, because these are very simple things and should be available everywhere actually.
Thank you,
So
ma'am.
thank you, Sonal, for sharing your knowledge. Our next speaker is Dr. C.B. Nagori. He is director, Dr. Nagori's Institute of Infertility and IVF, and he has got Best Paper Award for World Congress ESOG 2008 at Chicago. He got first stem cell pregnancy in India, and he has published several papers in index journals. First ever Center of Excellence for Ian Donald School of Ultrasound, and he holds regular trainings in infertility, IVF, and ultrasound. And he has contributed in several books. He has authored a very popular book, that is Handbook of Infertility and Ultrasound for Practicing Gynecologists. So he has done tremendous amount of work in the field of infertility and related ultrasound. So with this introduction, I invite Dr. Nagori for his speech, which is going to be very informative and knowledgeable for the people who are attending this meeting. So Dr. Nagori, please start presenting.
Thank you very much, madam, for the kind introduction, and thankful to Dr. Archana and all the colleagues for inviting me here on this webinar. The talk, medical management of male infertility. I think many people will consider topic as an obsolete topic in an era of IVF and ICSI, but I would like to emphasize how this can help you, how the medical management can help you as far as the treatment of the patient is concerned. All of you know that the 40 to 50% the male is responsible, and semen analysis is still the gold standard. And all of you know that WHO 10 criteria 15 million is a normal count. Why I want to emphasize this thing is because there are more than 60 to 70% of the labs in India today still writing down 40, 60, 80 million count as a normal count, and patient goes on taking the medicine even though the count is normal. So 15 million is a normal count, and these patients, they now generally don't require any treatment as far as the fertility is concerned. Now, what I want to emphasize here, one thing, that the morphology in an era of 99, when the IVF came or when the IVF was invented, the 15% was the morphology, and lots of IVF and ICSIs were done when the morphology was between 4 to 15% or the motility was less. Now, you can believe me that these were the patients where the IVF and ICSI were done would have conceived otherwise also, because today now we agree that the 4% is the normal morphology and the motility is only 32%. The treatment option is specific therapy and empiric therapy. I don't discuss much on the specific therapy because all of you know very well hypogonadotrophic hypogonadism means FSH low, testosterone is low, LH is low. So they all, when all these three conditions are low, but these are the patients where testosterone is usually normal, even though the smallest testes will have the normal testosterone, but the FSH and LH will be below the normal. And these are the hypogonadotrophic hypogonadism. This can be corrected very well. I'm just coming to a point. These are the causes: hyperprolactinemia, genital tract infection, disorders of ejaculation, immunological, isolated testosterone deficiency, congenital adrenal hyperplasia. These are all specific causes, and that's why the specific treatment is available for all these conditions. Just I give you that hypogonadotrophic hypogonadism. When I was a student, I was taught that when the FSH and LH are very low, then you cannot stimulate the hypothalamus and can increase the FSH and LH. And that's why clomiphene has got no role. But now there are a lot of papers which have come up that even if you give clomiphene in a patient of hypogonadotropic hypogonadism, 64.3% showed the sponge in an ejaculate. And the density was also 3.8 million per ml. So that's why clomiphene can be used in a hypogonadotropic hypogonadism man. Second is, many a times there is a gonadotropin deficiency and the HCG can be given to these patients and the spermatogenesis can be improved. Hyperprolactinemia, all of you know very well, can be treated with the bromocriptine, and all other causes, specific causes, can be treated very well. Now, medications and chemicals, this should be remembered very well that these are the things which are responsible for causing a male infertility. And the current is the electromagnetic field created by the mobile phones. Keeping the laptop in the lap as well as the using the mobile phone, keeping it in the lower pocket also can decrease the sperm count. Now, more than 25% of causes, there is no cause, and that is an idiopathic infertility. And that is why there is always a place of empiric therapy in a male infertility. What is empiric therapy? A treatment prior to final diagnosis based on the clinical concept and theory without proven efficacy, and only available form of the therapy in this patient is always the empiric therapy. Now let us consider one empiric therapy and what is its role. Clomiphene citrate, cheapest role, the only subgroup is improved and few may get a negative effect, but a small subgroup there is a vast improvement in the semen count, and 12.5 to 25 milligram up to 50 milligram you can give it for 3 to 6 months. Now when you give a clomiphene citrate, you should do a basal FSH level, and after giving a clomiphene, as it acts on the hypothalamus, it increases the FSH level. So after 1 month, if the FSH is increasing, it means the clomiphene is acting. But if the FSH does not increase after 1 or 2 months of the clomiphene therapy, then it should not be continued. Believe me, because I have worked in an era when there was no IVF, I worked in an era when there was no HMG or FSH were available. And we have used clomiphene to so many patients, and so many patients have improved their count and have conceived spontaneously also, not even with an IUI, but spontaneous conceptions are also there. So clomiphene is a very good drug. Second is an HCG. I'm a fan of HCG, that you can give 5,000 units twice a week and it can be continued for 12 to 24 weeks and gives an excellent improvement in the count. Now you can imagine that the initial reports which were studied were in 63 and 82, there were 60% improvement. I was talking to Archana that the invention on the medical management of infertility has been completely stopped after the invention of the IVF and ICSI. Companies are not financing any money in the Western countries for improving the sperm count as far as the medicine is concerned. They are ready to pay anything for IVF and ICSI recent advances, but they are not ready to pay anything to this. And that is why the research has stopped completely, because you can imagine that HCG which can give you 60% improvement, I think by this time a lot of other drugs would have come, a lot of analogs would have come and would have improved the count much more. So HCG is very effective. Even prior to TCA also, the HCG is very effective. Third is an FSH HCG combination. One is the Professor Isidori's regime. I'm also using this regime very well when there are FSH and LH, both the levels are normal. Then the bioactivity is different, because there is something like bioactivity and immunoactivity. What we measure by ELISA technique is always the immunological level. We don't have measures to assess the biological level of a particular hormone. So a same patient who is having the FSH and LH of the same level, biologically one patient may be having a less active bio-FSH while the other may be having a normal FSH with a good bioactivity. So these are the patients where the count is very low. Then you can give an FSH from outside, that is thrice a week can be given, an HCG once a week. That gives an excellent sperm count. When everything is normal, there is a idiopathic oligoazoospermia, or when this is Professor Isidori's regime, which should be tried when everything is normal to the patient. Androgen are just mentioned to condemn it, that it has got no role. Rebound can cause an azoospermia, and that's why androgen cannot be used. One of the very good drugs I have found in my practice is tamoxifen testosterone combination. WHO recommends this treatment that is anti-estrogen tamoxifen, and in idiopathic oligozoospermia, when motility and morphology are not significantly affected. So significant improvement in the semen quality can be from 33.9% versus 10% has been found with 20 milligram tamoxifen. 10 milligram Temtera tablet is available, which can be given BD, and Andriol tablet, testosterone undeconate, 40 milligram 3 times a day can be given, and both this combination can be given for 6 months, and it gives a very good improvement as far as the sperm count is concerned. Zinc, a very good drug. But the only thing you should always remember, the dose 120 to 220 milligram twice a day. Unfortunately, all the zinc preparations which are available in the market are only up to 50 or 60 milligram, and that's why you should titrate the dose accordingly, and it is very useful in oligozoospermia. Ketotifen, these were the drugs. Now, why I am mentioning this drug? Because these were the drugs which were used in the past, but further research has not continued about these drugs, and that's why these drugs are not used nowadays. But I think some other analogs or something more research can be done on this drug so that it can improve the count. And these drugs are, one is ketotifen, second is an appetizer, that is anti-serotonin agent, cyproheptadine and hydrochloride. And these I am mentioning because in the initial era of 90s, I have used these drugs, which improves the count and motility. Now you can read the figure, 33 to 50% can have an improvement of the count. Then why not to try this drug, and patient can have a natural conception or a conception by an IUI rather than going for an ART treatment. So these drugs needs further research and should be given to the patient for the improvement of the count and motility. Same is for nucleotides, same is for captopril, that is an antihypertensive drugs which were used in the past, but these are not used nowadays. Tissue hormones, pancreatic kallikrein can also be used. Anti-inflammatory drugs. These are very useful drugs. Tetracycline is a drug of choice, always should be given rather than finding the infection. It is very difficult to find out an infections, but it is always better to treat it, which is much more cheaper. And when you get a prostatic infection, then the quinolone group of the drugs can be given to the patient. Indomethacin, a very cheap, inexpensive and non-toxic drug, 25 milligram capsules are available. This can be given 3 times a day, which increases the count and motility. So these are the cheaper drugs which can be tried to the patient who cannot afford ART. Then these are the drugs which can be tried to the patient, can improve the count, and perhaps they may have a spontaneous pregnancy or pregnancy by IUI. Teslac, that is an testosterone which prevents an aromatization, and the base drug is anastrozole. Anastrozole is a hopeless drug as far as ovulation induction is concerned, but this is an excellent drug as far as the male infertility is concerned. It can be given 1 milligram daily, and it is a very promising drug, particularly when you want to prevent the conversion. Autocrine and paracrine system, stimulants are IGF-1, IGF-2, EGF and TGF that you can add in, or CRF beta endorphin system that prevents the spermatogenesis. So naltrexone that prevents the CRF beta endorphin system, and naltrexone can be given to the patient, or FSH can be combined with the growth factors, and that can improve the spermatogenesis. Now, apart from these drugs, now let us discuss the ROS, because there is a definitive role of ROS testing in the diagnostic situation remains to be established, although the detrimental impact of ROS on male infertility is now very well established. Systemic treatment of the man with antioxidants has received a great interest in recent years, but the story is still confusing because we are not sure which antioxidant is to be used to which patient. But always remember, antioxidants are complementary to the conventional treatment. You cannot give only antioxidants and can believe or you can have the drastic results with the antioxidant. It is always to be given, particularly when you are operated for varicocele, when you give an antibiotic for the infection, or you are giving anti-estrogenic treatment for the idiopathic oligozoospermia. These are the cases only that the antioxidant should be added to these patients. High doses of antioxidants have always theoretical adverse effects, and that's why please don't write it down 2, 3, 4 antioxidants to the patient. Any vitamin therapy in a normal man has got a questionable role, and B complex is out of place as far as the male infertility is concerned. And now antioxidants which are available in the market, there is a list of it, and let us consider one by one how it is useful to us. Antioxidant reduces the DNA damage, improves chances of pregnancy with an IUI, and reduces the abortion rate. DNA fragmentation test has been much controversial thing, and instead of doing a DNA fragmentation test, I would advise to give you the antioxidants to the patient and then assess the patient. I think that perhaps the results will be more different rather than taking the straightway the patient for an ART. Vitamin E that improves the motility, 300 to 600 milligram can be given to the patient. Astaxanthin nowadays is much more reliable, and we are all adding astaxanthin now instead of vitamin E. Vitamin C, the dose is 1000 milligrams. So whenever you select any preparation, and if you want to give vitamin C, it should be 1000 milligrams. Same way B12, 1000 to 1500. Why I'm mentioning the dose? Because there are so many combo preparations which are available, which are having 3 or 5 microgram of vitamin B12 or 10 microgram of vitamin B12, which are of no use. And that's why whenever you select any combo preparation, at least 3 to 4 drugs should be in a therapeutic dose. Then and then it will have some value. But otherwise, all the drugs in an homeopathic dose will not be of any help to the patient. Folic acid 5 milligram will be an additive dose. Pentoxifylline, that improves the count and motility. Nowadays, the radiation, because of the radiation, if the count is very low, people are using now pentoxifylline to the patient. Then selenium. Selenium is a very good drug that improves the motility, and particularly for 225 microgram is the dose. Available doses are only 60 or 80 microgram in majority of the preparations, and you have to titrate the dose accordingly. But you can see that the 50% can improve the motility in this patient. That's why it's a very good drug for the improvement of the motility. Glutathione, very cumbersome, intramuscular, it is to be taken intramuscularly, and that is why that has never become popular in the clinical practice. Arginine, 500 milligram tablets are available, or sometimes 1 gram, some company has come out. But if you want to give, it should be 4 gram per day, that is 8 capsules should be given to the patient. Now, one of the very good drug that is reported in human reproduction also, there are 2 papers, that L-carnitine plus L-acetyl-carnitine, this is one of the very good combination for the improvement of the count. Here the combination is very effective, and that is useful in idiopathic oligosteroteratosphermia and the low-grade varicocele when the motility is low. Then L-carnitine plus L-acetyl-carnitine sachets are available, and that can be given to the patient. Now it has a selective role in oligosteroteratosphermia. One thing to be remembered, that the positive effect does not last after the therapy. So whenever you are giving this drug, simultaneously you should treat the patient. You can't give the drug, wait for 3 months, and then you try to treat the patient. Perhaps the effect vanishes thereafter, and that's why it is always to be continued. Same is for coenzyme Q. Coenzyme Q is a very good drug, 100 milligram twice a week, twice a day should be given to the patient. And the same effect, that the beneficial effect does not last for a long time, and that's why whenever you are giving CoQ, simultaneously you should do an IUI, or simultaneously you should treat the patient for an ART. Otherwise, CoQ will not have the effect which will be lasting for a very long time. So for an improvement of the count, it will improve the count and simultaneously make the patient to conceive, because that improvement is not going to last for a long time. Vitamin D is under the study. There are various reports which are coming up that vitamin D is required to the patient, and vitamin D can be even given to the patient. Once a week can be given, and for 4 tablets will be enough for the patient. Same way, omega-3 fatty acids known as flaxseed and linseed oil, and this is very good. Omega-3 fatty acids have also now gained the importance that it helps in the good spermatogenesis. So these are the various drugs which have been used for improvement. Now these are the very busy slides I am showing to you. The only purpose of showing this slide, that in asthenozoospermia lots of drugs are available. You try to select few and you can improve the asthenozoospermia. Same is for oligozoospermia. There are a lot of drugs available for oligozoospermia which have got an effect for improvement of the count. And if we improve this count, then it will be very useful to the patient. So this I've already discussed, but just I'm showing this slide that these are the dosage of the various drugs which should be remembered, and it should be given in a proper dosage. Otherwise, it will not be of any use if it is used in a homeopathic doses. And same ways for all antioxidants, they should be given in a proper dosage. Unless you give, so whenever you select any combo preparation, it should be selected in such a way that at least 3 to 4 preparations should be in a therapeutic dose. Then and then that combo preparation will have some effect. Now, why I want to emphasize only the last point is that the medical management of oligozoospermia is the most neglected segment of the infertility management, especially in an era of IVF and ICSI. And the purpose of this medical management is to make the patient conceive with a less advanced ART, convert an ICSI cycle into an IVF cycle, or an IVF cycle into an IUI cycle, or an IUI cycle into a natural conception by improvement of the count. This is the tip of the iceberg. I've got many such cases on my records, but this is one of the beautiful cases which I would like to demonstrate. That industrialist, 9 years of infertility, semen count 3 million, 7 ICSI failure. There were 7 ICSI failure. So don't try to sail in the same boat what your colleagues have done, because my all colleagues did excellent ICSI. But in spite of that, the patient did not conceive. And that is why what you should do, you should do something else than what other people have done. And in our practice, always remember, I was talking to Archana, that I started with treating a male infertility when I started my practice in 91. And perhaps no gynecologists were treating male infertility at that time. And that's why I could pick up my practice. So that's why try to find out what your colleagues have missed, and that you should do. This patient was treated with Professor Ishidori's regime, that is FSA thrice a week and HCG once a week. The count increased to 22 million, conceived in the second cycle by an IUI. And as the count was 22 million, spontaneous conception after 2.5 years, and patients have got 2 babies at present. So this is how you can help the patient. There are a lot of patients where the count can be improved and they can conceive here also. So thank you very much.
Thank you, sir, for the wonderful presentation, and it cleared, I think, lots and lots of doubts which we all face in day-to-day practice. And the case study was a star maker for the day with the presentation. It is such a absolute that sometimes even after doing IVF or ICSI, we don't get the result, and by just treating the right parameters, we do able to give the happiness to the patient. So we just have few questions that we would like you to take in.
Yes, definitely.
Yes, sir. So the first question, sir, that we have is that when the count is 10 million, which drug do you start?
See, arbitrarily, I would like to tell that you divide the patient in 0 to 5, 5 to 10, and 10 to 15. Majority 10 to 15 million counts can be treated with the drugs, oral drugs only. When the count is between 5 to 10 million, then I give an oral drug along with an HCG. HCG 5,000 twice a week is an excellent drug that can be used when the count is between 5 to 10 million. And when it is 0 to 5 million, try to find out the cause. If there is no cause, then I would like to go with the Professor Ishidori's regime, that FSH-HCG combination can be given to the patient, and the oral drugs like tamoxifen and testosterone combination can be given to the patient. That can help the patient very well.
Okay. So the other question what we have is that, like in the females, we do the FSH on day 3. Is there any particular day that in the males you want to do the gynecological assessment?
I just tell you that when you investigate a male, then only do one test, and that is FSH. If FSH is high, LH may or may not be high. But if the FSH is high, it means it is either an AID or adoption. There are only few cases where the people like Rubinsa is available in your town. Then you can do a micro TC and then you can do an ICSI to the patient. But otherwise, with the majority, I have seen with an andrologist also that it is very difficult to get the sperm by doing a micro TC also. So then and then only you can go for a micro TC. Otherwise, these are the cases which are for AID or adoption.
Okay. Thank you so much.
Excellent talk, Dr. Nagori. I think, you know, when it comes to like what kind of a specialty you take, so even in IVF or in the infertility, you should have people expertising in male infertility and female infertility, because male infertility is somehow is a neglected area. That's what was the whole idea of taking up this seminar. Shia Kalyani, is there any more questions, or we just have to go?
We have one question for Sonal ma'am, if she's there.
Yes.
Tell me.
Yes.
So it's in regard to the varicocele. Just 1 second, ma'am.
Tell me.
Yeah, so ma'am, the question is that when would you ask the patient to take a medical line of treatment in case of varicocele, or when will you suggest the patient to do a surgery in case of a varicocele?
That question is not mine, it is his. Let him
see. What the principle is, when you get an abnormal semen analysis with a varicocele twice, it means it requires a surgery. But if the count is normal and the varicocele is present, I will not operate that patient. I will either go with the spontaneous conception, ovulation induction, and or I can do an IUI and the patient can conceive. Or medical treatment, additional medical treatment can be given to the patient, like antioxidants and this.
Right. Okay, I think we are done with the question and answers. Basen ma'am, would you like to take it?
Yeah, I think we just move ahead with the panel. Thank you very much, Dr. Sonal and Dr. Nagori. It is always pleasure to have you on the forum, and it was mesmerizing talk. Actually, I think everybody here must have been enriched by your immense experience and the time you have really put in to the treatment of the male infertility. I have really seen you working, and I've seen your workplace, the way you work, and really thank you very much for sparing time and sharing your knowledge here. So thank you. And if you can stay for the panel, if you have no other commitments.
I'm here because I have to go at 6:30.
Okay, so thank you so much for being with us. Thank you, Sonal.
Thank you so much, sir, and thank you so much, Dr. Sonal ma'am.
So we can go ahead with the panel, Dr. Kalyani, and we can have we can welcome all our panelists and their seats can be.
So let us start with today's panel. So the today's panel is basically how to optimize the success in the male infertility, and the moderators for the day is Dr. Archana Basair ma'am. Basair ma'am is the FOGSI Vice President 2020, and she is also the Organizing Secretary for AICOG 2020 Indore. She has been, she's also the representative of RCOG West Zone. She has been the past chairperson for FOGSI Imaging Science Committee 2015 and 2017. Together with her, joining is Ramini Devi ma'am. So Ramini Devi ma'am is the director for the Janani Trichy Fertility Center. She is the National Vice President FOGSI 2020. She is also the International Advisory Board member of Endometriosis Society of Bangladesh. She is the best. She has been awarded as the Best Women Doctor Award by Tamil Nadu State, and also the recipient of Dr. Durusha Distinguished Community Service Award. I think she has got multiple national awards that she has received, and the list is endless. She has also received the prestigious Dr. APJ Abdul Kalam Azad Award. And the podium belongs to you, both the ma'ams. We can start with the panel now.
Thank you, Dr. Kalyani, for the nice words spoken. I think we really appreciate the two speakers who have done excellently well. Now we have again galaxy of panelists with us. Can you stop sharing your screen? Okay, then. So now okay, go ahead with Dr. Sanjeev Reddy sir's screen, introductory slide. So I welcome Professor Dr. Sanjeev Reddy sir, who is the professor and head of the Department of Reproductive Medicine and Surgery of Sri Ramachandra Medical College. It is he has the credit of having the first department in the University College to start the first super specialty course in OBGYN, MCH in reproductive medicine and surgery. He has been a BC Roy Award and Eminent Teacher Award, an expert panel member to Medical Council of India to formulate the syllabus and minimal eligibility criteria for MCH in reproductive medicine and surgery. He has been an expert committee member to prepare syllabus for fellowship in reproductive medicine, fellowship in clinical embryology to NTR University of Jayawada, honorary consultant and external board member of JIPMER to established IVF center at JIPMER Pondicherry, founder secretary of TAPISAR, past president of FOGSI, organizing secretary of All India Congress AICOG 2015, and organizing secretary of ISAR 2015, and organizing secretary of UISAR 2018, and the annual national conference at Chennai. He is a very nice person and a very friendly person, and he is a teacher par excellence, and he has got so many so many awards and credits to him. I welcome you, sir, for this panel. Your presence will really make the change in the panel.
Thank you, madam, for your kind introduction. Thank you.
Next, CV.
And again, Dr. Kunju Moideen, who is a young star of Kerala, who had his advanced training in laparoscopy, France, and training in ART at Singapore, chief consultant at Maulana IVF, and then now he is a senior consultant in ARMC IVF Kozhikode, and founder managing director of ARMC IVF network at Kerala, Karnataka, and Tamil Nadu, chairman for ARMC AEGS Hospital Perindalmanna, and a visiting laparoscopic surgeon to so many hospitals overseas, and the infertility consultant at Doha, Qatar, etc. Then visiting consultant and IVF specialist at Modern Isalama Medical Center, Muscat, and areas of interest are ART and laparoscopy. Joint Secretary, Indian Fertility Society, and President of Perindalmanna Society. He is a very, very young, dynamic person who involves in so many of the academic activities, and every activity he does from Perindalmanna Society, which is a very young society, is wonderful. I welcome you, Dr. Kunjumaidin.
Thank you, ma'am. Thank you for the nice words.
Then I'm happy to introduce Dr. Vidya Dubey, very close friend of mine, who is the professor and head of the Department of OBGYN of Al-Amin Medical College, Vijaypur. She is currently the chairperson of Food and Drug Medico-Surgical Equipment Committee, and doing almost every day. If you see the WhatsApp group, there will not be a single day without her program. And she is the national corresponding editor of Jogi, organizing chairperson of Kasoga, treasurer Kasoga, EC member of KSC KGOI, an academic council member, Women University of Vijaypur, Al-Amin Medical Journal of Medical Sciences editorial board, UG, PG examiner and paper setter for the PG guide, and she has got a vast teaching experience of more than 30 years. And I welcome you, dear Dr. Vidya Dubey.
Dr. Ragini Agrawal. It's my proud privilege to introduce my colleague and co-vice president of 2020, very dynamic person. She is founder of Gurgaon Obs-Gynae Society, founder president Haryana Obs and Gynae Society. She is president-elect of Aesthetic and Regenerative Society of India. She is founder president Haryana Association of Gynec Endoscopic, and she is founder Chief Secretary Indian Menopause Society Gurgaon chapter. We welcome you, Ragini. I think she might be a little late if she's not here. So we will be inviting her again. Is Dr. Bakshi here?
Yeah, I saw her.
Yeah. So I think it is again a very, very proud privilege to introduce my very close friend and a very dynamic and very, I mean, she's a jewel in MP's, she's a jewel of MP, and she is Fertility Committee of FOGSI. She is joint secretary of ISAR 2020 to 21. She is founder chairperson of MP IAG and MP ISAR. To her credit goes the first ICSI, TISA ICSI and micro TC ICSI babies of MP. She is recipient of Dr. Kumud Tamaskar Award FOGSI 2008 and 2009, and she has best papers in FOGSI journals 2011 and 12. She runs FOGSI recognized infertility and endoscopy courses and certificate courses of ICOG. She has organized many conferences like Star Endogene, ICCON, and joint organizing secretary of IFSS 2016. And she is organizing chairperson of AICOG 2021 to be held at Indore. And she has too many crowns in too many jewels in her crown, and one more she is eyeing for is, and she is really she is going for vice president elect from the West Zone, and I request you all to really vote for her. And here I invite my friend Dr. Asha Bakshi. Is she here?
Yeah, thank you so much. Thank you so much, Archana.
Next is Dr. Rupin Shah. Welcome, Dr. Rupin Shah, to this panel. It is really nice, and we are honored to have you on our panel. He is consultant urologist and microsurgeon, practices microsurgery and andrology at Leelavati Hospital in Mumbai. Dr. Rupin Shah has been trained at Belgium and in andrological microsurgery, and he did his MCH. He is the first urologist in India to have this training and is a leading expert in area of microsurgery for treatment of men with azoospermia and microsurgical vasectomy reversal. He has conducted numerous workshops. He has written many chapters in the books. He has conducted numerous workshops in India and abroad, and he is associated with several IVF centers and has a vast experience in sperm retrieval procedures, including PC, and has innovated new approaches. He has publications and he has written 26 chapters in book, and he has co-edited 2 books, and he was the editorial board of Indian Journal of Urology, and is a super specialty consultant in andrology to several organizations. So it is really, really going to be a good, intense panel discussion with panelists from different walks of life, from north and south and east and west of India. So we are looking forward to this great evening with all our esteemed panelists. So we can start with our case scenarios. Dr. Ramani, welcome you all.
Thank you.
Video. Just 1 second, give me 1 second.
Yes, I think the topic is optimizing outcome male infertility. We all know, and I think all of our panelists are here on present except the Dr. Ragini Agrawal. I think before Dr. Ramani starts taking the first case, let me tell you why we selected for this panel. I think it's lot been discussed about it. That because we are invariably investigations and treatment focus mainly on female partner, and we really want to bring attention to male factor infertility. We had very nice and interesting and good talks by Dr. Nagori and Dr. Sonal enlightening us on how really male factor infertility is not being that very well treated and taken into account. And various options are available in cases of azoospermia and oats. Do not write off the cases of azoospermia that you cannot conceive. We have super specialists like Krupin Shah and others here on the panel. They'll really tell us how really they can be helped. And really we are going to discuss routine cases, scenarios with expert inputs. They are not out of the box cases. They are just routine cases which are being encountered by gynecologists on every infertility specialist and routine gynecologist on daily basis. Over to you, Dr. Ramani Devi, for the case.
Yeah, thank you, Dr. Archana. First of all, why this panel? More than this, I think we are the the gynecologists are the first person who are able to pick up the semen, abnormal semen parameters in the male partner. So that is why we thought we will have this panel. And at the end, with a galaxy of panelists among us, we'll be able to give a clear take-home messages. Our previous speakers have very well enumerated that male infertility ranks to 40 to 50%. And again, we have so many reasons for male infertility, namely the obstruction, or it could be a immunological systemic problem, malformation, hypogonadism, infection, varicocele, and at the top you can see that idiopathic male infertility is the commonest cause of oligoastenospermia in males. So going to case 1, a 32-year-old male patient came along with his partner with inability to conceive since 5 years. The couple are employed in an IT sector, stressed, working for night shifts, coital frequency only once in fortnight. Husband takes alcohol regularly and smokes more than 10 cigarettes, and couple are obese and do not indulge in any regular exercise. How will you counsel them? That means here I am presenting a couple who have got all reasons to say that they remain infertile. So now let us discuss how we are going to counsel them.
Dr. Sanjeeva Reddy.
Sanjeeva Reddy, sir. Can
Madam,
you take? Yes.
Yes, here this they are stressful. So first thing is lifestyle changes is important for them. So this we have to take detailed history from the both husband and wife. And once if you say the wife is normal, most of the time the mother-in-laws will be blaming only the daughter-in-laws are at problem. It's not like that. Both of them we have to take detailed history and do the clinical examination. And at least minimum investigation for the female is the transvaginal ultrasound. If it is normal, then at the same time I'm going to take detailed history about the male partner and clinical examination. Then I will give the minimum investigation is semen analysis for him. Meanwhile, he is having other problems here. One is like he is stressed. We have to tell them how to reduce the stress, and he's taking smoking and alcohol. The two things are grossly affects his semen parameters and also fertility. And you told one more thing is overweight something.
Yes,
These are things. For that, first thing is we have to change his lifestyle change, that is important. Depending upon the semen report, then we have to proceed further.
Yes, sir. So you have completed the female also should have a basic evaluation, and that was done by a transvaginal ultrasonogram, and a tubal patency was checked up. Hormonal profile was remaining normal. She was also advised lifestyle modification. So evaluation of the male partner, you said clinical examination is a must, and he was found to be a borderline hypertensive and a diabetic. Basic investigations done. Semen analysis was done, counseling was done. So on clinical examination, what are the basic things would you like to see in this particular patient, sir? Can you enumerate?
Okay, just we have to see first itself whether it's looking normal or abnormal, like height, whether he is normally androgenized or not.
Yes.
And from head to toe, we have to examine this patient also, whether there is any like proptosis, and just if you come down, whether thyroid is enlarged or not, their breast examination, whether there is any gynecomastia is there,
yes,
things. Then like we are coming from the external genitalia is important. Both inguinal regions also we have to check whether there is any herniation is there, the other things, any scars are there, previous things. Then examination of the penis. So like this here, we have to concentrate whether there is any phimosis is there, the external urethral meatus is in the normal position, whether there is any strictures or something is there in the urethra also you have to make out. Then come down, just see the scrotum, whether skin is normal, whether reflexes are present, whether there is any varicocele is there. I just first examine by standing position, then palpate the testis, whether it is a normal size, consistency is normal, whether there is any tenderness is there, then check the epididymis, palpate for the vas, all the things. If needed, we have to check the like rectal examination also we have to do. With this, most of things we can get. If needed, then for after seeing the semen analysis also, then we have to decide whether to proceed with other things or not. If the semen analysis is normal, then no need for us. We can get 3 types of semen analysis report. It may be normal. There may not be any sperms at all, like azoospermia or oligoteratospermia, or isolated defects also you can get. Depending upon that, then we will decide what to do next.
So the main reason why we put up this question is, do we need to, as a female gynecologist, see, we may have some restrictions in examining the male partner. So just can we take the semen analysis as a basic parameter, and if it is found to be normal and the external phenotypic appearance, that is if he is well androgenized, then we can take it that he may not need a further evaluation. But on the basis of semen analysis, I think you have rightly pointed out that he has to be examined by a male gynecologist or an andrologist or a urologist.
No, just 1 second.
Yes, sir.
No need for us to spend smaller things for this person to urologist or andrologist, madam.
That's what I am telling. So
yes.
Suppose we don't have a urologist in that particular place, a simple yes. examination by a general surgeon or an in-house male doctor can do the examination. So just that is what...
Simple size of the test itself will give us maximum information along with semen analysis.
Yes, sir. So Dr. Kunjumadan, you want to add something?
Yeah, for a female gynecologist also, a normal semen analysis, that do not mean everything is fine. So we have to look for other factors like hypospadiasis and phimosis. Like that, local physical examination also is important, even if there is the semen parameters are normal.
So the semen analysis of the particular patient shows only volume of 1 ml with 4 million per ml sperm count. Motility of progressive motility is only 6%. Morphology is around only 1% is normal, and round cells are more than 5 million, and it is fructose positive. What are the probable clues we can say that what is the problem that is lying in that particular patient? Kunjumadan, you want to take up this?
Yeah, so here the volume itself is less. Usually we consider a volume of more than 1.5 to 2 ml is considered as normal. And the sperm count also here, there is oligospermia. The motility is also less. Ideally, we consider as the type A and type B motility is considered a total of more than 32%. And at least the normal morphology based criteria should be more than 4%. And the pus, the round cells generally considered as due to the pus cells or so. And the fructose is positive. And here it is considered as severe oligosteroteratospermia because all the factors are abnormal.
Yes. This one. Not moving.
Hello?
Yeah,
Yes,
Dr.
not moving. Just I have some problem here.
No, on the
Yeah. So comment upon this semen analysis. You have already said that it is a case of oligoastenospermia. And next the question is whether we need to go for a semen culture because the round cells are beyond 5 million.
Yeah, actually, see, generally when there is a round cells are beyond 5 million, ideally it is better to do a semen culture. In most of these patients will go for assisted techniques like IUI or IVF or whatever it is. A basic semen culture is always better.
So again,
Can I add one more thing, madam?
Yes, sir.
Just by seeing one sample report itself, we should not react actually. We have to repeat always one more sample. How long after you are going to repeat, that is important question. There may be, depending upon the things, always, even though in the beginning they were telling 3 months, like no patient will wait for 3 months, at least 1 month we have to repeat these things. But in this case, usually what I will be practicing is, just if you ask the patient to go and come back after 2 weeks, we'll report that the patient won't come back. For that, usually I will be starting the doxycycline 100 milligrams BD for 2 weeks. Then I will ask the patient to come back. Then again I will repeat the sample. If it is still persisting the same thing, then only we will give importance for that one. By seeing just one sample itself, we should not react. That is
what I expected, sir. I think the universal can go ahead with the doxycycline antibody, a doxycycline antibiotic, rather than initially itself going in for a culture. Then.
Even giving antioxidants is not a bad idea in these patients because you have to give them something before they really go. So antioxidants also may help such patients.
Okay. This
I think, see, empirically should we give antibiotics empirically in the beginning itself, whether it is doxycycline when we see the pus cells. I think it may not be the correct way. I think Rubin Shah sir can add on that point.
I think the point mentioned on the slide was very important, that round cells have to be distinguished from peroxidase positive lymphocytes. 80% of samples that I see which are labeled as pyospermia, when we retest it at a proper lab, turn out to be normal. And a large number of men receive unnecessary antibiotics because the round cells were not distinguished. There are 3 types of cells that look like round cells. The actual leukocytes, then spermatocytes and macrophages. Only leukocytes are indicative of infection, and the cutoff is not 5 million, it is 1 million. More than 1 million of peroxidase positive cells per ml would be considered diagnostic of leukocytospermia. So the important message is that if the round cell count is less than 1 million, don't worry. If the round cell count on an unstained slide is more than 1 million, it needs to be stained before a diagnosis is made.
Then anybody wants to have a definite abstinence period of 2 to 3 days before the patient gives the semen analysis, or you just do it as the patient comes, irrespective of the previous coital activity.
We can do the semen analysis.
More abstinence.
Yes.
Finish up, Kunjubde.
Yeah, please, sir. Please, sir.
So we can do the same day, madam. Whenever his patient is coming, previously we are advising like that, minimum 3 to 5 days. Nowadays we can do the semen analysis, no problem. Suppose if it is normal, no need for us to go and repeat. Suppose if it is abnormal, then next time when the patient is coming, that time you can advise them these things all. I don't think definitely first time itself you should ask like that to wait for 3 days or 5 days to abstinence, then you give.
Sometimes we see practically that on the day, the first sample may not be good when they come for IUI, but the next day morning, if you ask them to come and take a repeat sample, it looks fine. So abstinence really doesn't matter much, except in cases of very severe oligoosmosemia. This semen analysis of whose criteria has been projected already. Then how do you in general interrupt the semen analysis? Basic, anybody can take up this question.
Dr. Rupin Cha, you can just...
Okay, so if they're normal semen parameters, then the initial focus is on the wife, but what has been missed out so far in the case history is the sexual history. They are obese, they are stressed, they are not active.
Even the sexual history once in fortnight. There is no frequent coital history.
So if they're having sex once in a fortnight, that could be a primary reason, not the primary sperm count is low, but an important reason for not conceiving. So if his semen parameter had been normal, which is the left scenario on this slide, then the sexual history would be very important. And very often these men require sildenafil 50 milligrams 1 hour before intercourse during the peri-ovulatory period. So they manage to have intercourse in that fertile week, because otherwise they keep on missing the important days. So that would be relevant for this couple. If poor semen parameters are there, here, as you've already emphasized, the lifestyle changes are very important. I would strongly emphasize that for the patient and tell him to come back after 3 to 4 months, having lost weight, having exercised, having eaten correctly, and then recheck the semen. And we are often surprised by how much the semen parameters can improve. Of course, if it's azoospermia, I think that will be another case where we need to have an extensive discussion.
Then anything to do with the profession and the vote, I think you have mentioned already this point very clearly. Now,
here ma'am.
Yeah, tell me.
Here in this particular case, because of their duty patterns, you have clearly mentioned they are taking night duties, and that's why they're not getting the opportunity to have proper intercourse. May not be the erectile dysfunction per se.
Yes. So how do you manage this particular patient? I think all these things have been answered. Lifestyle modifications, smoking, alcohol. And is there a role for antioxidants in this particular patient? Or you want to extensively investigate the male partner?
There's no harm in giving antioxidants, and I would like to give antioxidants in such patients.
Yes. Okay. Then repeat semen analysis after 3 months. Or you, because now it has been said that even 60 to 70 days is enough for a sperm to be formed. Do you want to repeat it even much lesser period than 3 months?
No, madam. 15 days or maximum 1 month is enough, madam. 3 months nobody stays. Yes, because suppose it has something happened previously 1 month back or 15, like 3 months back, we had some fever or something, then we can see whether it is still that 5 millions or 4 millions are increased, that it will give us. 3 months nobody will wait, madam. That's the one thing. Here,
does it mean whether they repeat after the antioxidants or after the first analysis?
No, and see, first we have to diagnose what is the problem actually, whether our diagnosis is correct or not. Antioxidant, just like that, you can give like vitamin like that, they can be continuing. It's not going to create any problem for the patient. No, if you want to go for the main treatment, first you have to diagnose. Without diagnosis, we cannot put all the things just like that. Here, his count is low, his motility is low, morphology also is very low. Just like that, we cannot put only an antioxidant and send him like. We have to find out what is the reason. Here, it is only thing, my thing is, he is obese, other things, I have to go for the hormonal evaluation here. So the hormonal evaluation I will do here is FSH and testosterone important. In addition, because I want to finish all the investigations here, LH and estradiol also I will estimate in this patient. Depending upon that, I will take the further process.
Sir, what about TSH, sir? Because of his obesity, it could be some hypothyroid element could have been the cause for OAT. So I think I will add up some TSH also along with FSH.
Diabetes also, I think we should check these patients for
Yeah,
diabetes.
that I have given in the history is, I mean, is a borderline diabetic and a borderline hypertensive. All those things have to be corrected.
Yes,
Okay.
so there are two ways, madam. Finish up all the test beginning itself, then you can say there is, if there is anything is there, you can treat. Otherwise, the other way is like, depending upon you identify this may be the cause, then you do the test. Then if that is normal or abnormal, then you go like that. As you are telling, definitely we have to exclude the whether he is diabetes or not, other things. So thyroid assay also we can do because of obesity, other thing. There may be chance is there that also you can exclude.
Along with testosterone, is there any role of checking estradiol levels also?
I told yes, definitely.
Yes,
Like estradiol, you have to check whether there is a testosterone estradiol ratio is changed or not. You have to find out. Depending on that, when you decide to go for the medical management, definitely it will help us.
Yes. So in what way it will help, sir? If the estradiol level is found to be higher, which sort of
testosterone estradiol ratio, if it is less than 10,
yes,
then we have to go for the aromatase inhibitors to correct that problem.
yeah,
If
that
estradiol is very high, then it is going to, if you go for the medical treatment, is not going to help us. So we have to reduce the estradiol, correct that ratio.
So the message here is we should assay estradiol level also in some of the patient. Then these are the effects of smoking upon semen. It reduces the concentration, motility, and increased DNA fragmentation. And there are so many other impact of smoking, alcohol, and drug that it can reduce not only oligoastenospermia, and alcohol can reduce the volume, motility, DNA damage, and recreational drugs, and as well tobacco can alter the LH-FSH ratio along with the alcohol also does the same thing. And so because of all these problems, the patient has to be warned that he should get rid of all these problems. See, there is again a passive risk of smoking for this female partner also. Now, how can you say that what are the problems leading to increased ROS in this particular patient, and what about the role of antioxidants?
So here you have already mentioned about a lot of factors the male partner is having, like smoking, alcohol, no exercise, obesity, and the night duties means the lack of proper sleep. All these things can add to the increased DNA fragmentation levels in this particular patient.
So there is a chance that the patient is likely to have an increased ROS, and so antioxidants can be done. So do you want to do routine sperm function test for this patient, particular patient?
Not exactly.
No, not exactly.
Not routinely.
Okay, so these are all just for completion sake. I have given the sperm fragmentation. If at all you want to do a single special sperm function test, what would you like to do?
One each can tell.
Actually, sperm, if it is semen analysis normal also, suppose the patient is not conceiving, previously you tried the IUI, she is not conceiving, or like this type of severe oligoastenospermia. Here these patients, but DFED, DNA fragmentation index will help. That is the only test we can go for. If it is increase higher, then that is an indication to go for the antioxidant. We cannot say definitely it is going to help us, but it will, we can give their antioxidants.
So that is the message we wanted to give. There is no need for a specialized sperm function test, except that DFI might help. So these are all some of the literature evidence to say that you can have an increase in the pregnancy rate as the DFI goes down. So biochemical test, ROS, we are not routinely doing all these investigations except in research situations. Then all these things I have. One important thing is reactive oxygen species affects the motility through peroxidation of sperm lipid membranes and midpiece abnormalities, and affects the sperm oocyte fusion. So this is one important reason why we should always try to reduce the ROS levels. Then is there any role for micronutrients in male infertility?
Yes.
I think from Dr. Nagori's talk, He has given an excellent insight about the role of micronutrients like zinc, selenium, vitamin C, and so many other things. L-carnitine, enzyme Q10. I think we can skip this. So again,
but
this
mostly this micronutrient combination, the quantity of the elements will be very less. Like Dr. Nagori sir explained properly that vitamin C, which are available in the pharmaceutical preparations, also is very less.
Yes.
So that's why we may have to give sufficient quantities to have the desired effect.
Okay. So this was a review of Cochrane review in 2011, where they say improve the outcome of live birth and pregnancy rate for subfertile couples undergoing ART cycles. Probably they can act by reducing the DNA fragmentation. And regarding the miscarriage and sperm count and motility, they say there is no effect, but again, adverse effects are not noted. So now it's a newer thing, upcoming field about the role of microbiomes in relationship to any sort of disorders to infertility as such. Can anybody focus something about the seminal microbiome and its function?
See, it's a non-factor that any sort of microbiome involvement, like it can be arising from the prostatitis or epididymitis or anything, that can very well affect the sperm quality, sperm morphologies, and specifically it can increase the DNA fragmentation, and it can very well impact the post outcome following any procedures involving the IUI or ARTs.
That is, each seminal fluid has got its own microbiome, and alteration of that microbiome that has been overtaken by the pathological organisms can affect fertility. So the key points what we would like to give from this particular thing is severe oligoacinospermia is a major cause for male infertility. Smoking, alcohol, obesity, work stress, varicocele predisposes to vote, and lifestyle modification is a must, and paternal karyotyping is not of much use. There are defective DNA function, and there are increased ROS formation. There is a role for antioxidants, and IUI and ICSI may be the treatment of choice to improve fertility. So next, I hand over to Dr. Archana for the next case.
Yeah. So I would like to bring Dr. FOGSI here in this case. It is a 29-year young medico. She has regular menstrual cycles, normal BMI. She has no history of pelvic infection, no known medical problems. On investigation, her all biochemistry is normal. Physical examination revealed no abnormality. And male partner is an engineer. Doctor, can we have the next slide, please?
Yes.
Yeah. He's an engineer, no smoking, occasional alcohol, regular exercises, healthy diet, normal BMI, no known medical illness, and couple is trying for pregnancy for 6 months. Very hale and hearty couple. You know, they know nothing which you can think of as a problem. You ask for the baseline investigations. Their coital frequency is also regular. And when you ask for the reports of the male partner, next slide please. And semen analysis report is azoospermia. It comes as a really shock and a blow to the couple. How are you really going to counsel, and how you are going to direct their treatment further?
I think first of all, the report should be revealed in a very subtle way. You should be empathetic to the patient, because sometimes, especially in the case of male, it is really shocking when they come to know this. So you have to be very sympathetic to them. And it's always a good idea to repeat the semen sample at least twice or thrice. And when the semen sample is being done, then you instruct the person who is doing it to centrifuge and check if there are any sperms or not. And if that is so, then it would be a good idea to examine the couple. I mean to say, examine the male partner to check for congenital absence of the vas, because in these cases the prognosis is quite good. And then to do the blood tests like FSH levels, because if FSH is low, then there may be a reason that they've got hypogonadotrophic hypogonadism. do FSH and if it is normal, then maybe there is obstructive azoospermia. So, and I think you can do Doppler, but I don't see much role of Doppler in these cases. And karyotype, especially if this is a case of congenital absence of VAS, then in that you have to check for the cystic fibrosis. And if it is hypogonadotropic hypogonadism and or any other, or just non-obstructive azoospermia, then maybe you may check for micro deletion, Y micro deletion. And there are 3 types of Y micro deletion. So in one, you can get sperms if you do the TISA. So it's very important to do the investigation, talk to the patient, and explain to them that still you can have a baby with your own genetic material. So I think, but most important is to be very, very careful while revealing this diagnosis.
Thank you so much. And you have done the investigations and found that report is serum FSH is 50 milli international unit per ml. And your scrotal sonography and Doppler, as you said, that you do not normally do it, but they got it done and it was normal. So now the patient goes to Dr. Rupin Shah. And Dr. Shah, how do you really ascertain whether it's an obstructive or a non-obstructive azoospermia?
So the differentiation depends on many things, including history. If there was a history of hernia surgery, hydrocele surgery, it's possible there's an iatrogenic obstruction. History of mumps, chemotherapy, etc., most likely non-obstructive azoospermia. History of undescended testes, non-obstructive. So history will give you a clue. Then the semen report itself, even before you examine the patient. So you just said azoospermia, but if the semen report showed 0.5 ml azoospermia, 95% of the times that is vasoaplasia. So sometimes the volume and fructose will give you a diagnosis, obstructive or non-obstructive, right away. Or a very low volume could be an ejaculatory duct obstruction. Then in the physical finding, based on the testicular size, testicular consistency, and the epididymis, whether it is turgid or flabby. So small, soft testes, flabby epididymis, non-obstructive. Good sized testes, turgid epididymis, more likely to be obstructive. And then the FSH. FSH more than 1.5 times to 2 times normal, it's non-obstructive. FSH and testosterone and LH all way below normal, that is hypogonadotropic hypogonadism. Normal, now this is important, normal FSH does not guarantee sperm production. This is a common mistake that people make, that azoospermia FSH is normal, that means he has sperm. Not at all. Half the men with testicular failure will have normal FSH. So therefore, it's not one single parameter. You have to look at everything. And on that basis, sometimes it may be very obvious that it is testicular failure, as in this case, where the FSH is 50. Sometimes it may be very or fairly obvious that it is obstructive. And sometimes it's equivocal and you need something more before you can tell whether it's obstructive or non-obstructive.
Dr. Rupincha, do you do a testicular, would you be advising them testicular biopsy? And the next question is, does the testicular biopsy hampers the results, in the future?
Yeah, testicular biopsy is kind of obsolete nowadays. If you do a single biopsy and it shows sperm, okay, it helps you, but if it doesn't show sperm, it doesn't mean anything. You could do a testicular biopsy, not find sperm in 1 or 2 biopsies, and then find sperm when you do multiple biopsies. So when would you consider a testicular biopsy?
Yeah.
Not in this case where it is obvious non-obstructive azoospermia. Where the diagnosis is clear, there you do not do a testicular biopsy. Where the diagnosis is not clear, normally I would not do a testicular biopsy. I would plan on a sperm retrieval procedure. One sample will go for histopathology and the other samples will go to the IVF lab, because sometimes a single biopsy may not find sperm, but the IVF lab may find a few sperm. So if it's an equivocal case, we will do multiple biopsies, usually with a needle. One will go for histopath. The remaining samples will go to the IVF lab. If the IVF lab finds sperm, they will freeze those sperm.
So have you ever experience of, like you have a vast experience of doing micro TC, do you have any comparison or any studies where people, those who have come after the testicular biopsy, because it is invariably a practice, when the spermatozoa are not found, some people will do the biopsy. So is there any difference in retrieval, sperm retrieval amount or the quantity if they had testicular biopsy done, or if they have not done the testicular biopsy?
Usually a single biopsy won't matter, though you'd still have to wait 3 months after the biopsy before doing anything. But sometimes people do an FNAC where they poke the testes in multiple directions, and that can compromise sperm production for 3 to 6 months. So it's better to have a virgin testes.
Okay. So now the couple, they don't want to go for third-party reproduction, as Dr. Bakshi has already said that even in the azoospermia, give them a hope, give them a chance that yes, you can have your own baby. So they have decided, okay, we want to have our own baby, and they have heard about micro TC. They come to you. So Dr. Shah, how do you really select cases for micro TC? How do you do counseling? And would you like to share some major, minor, or rare problems associated with micro TC?
Sure. So the first thing about micro TC is that there is no predictor as to which patient you will find sperm in. You may find sperm in very small testes, like the size of a pea, and you may not find sperm in a large testes. FSH does not predict whether you will get sperm. The highest FSH at which I got sperm was 80. So higher the FSH, more is the testicular damage, but it doesn't mean that there is a 0 chance of finding sperm. Similarly, inhibin is also not completely predictive. The only thing that has some predictive value is if you did the YQ microdeletion and a patient has AZF-A microdeletion or AZF-B microdeletion, there we will not find sperm. If it's an AZF-C microdeletion, it's about a 30% chance that we could get sperm. So basically, yeah, if this couple comes and says, Doc, do we have hope? Yes, you have hope. What are your chances of finding sperm? About 25 to 30% in this case. What would be required? Microtesting would be required, because when FSH is very high, most of the testes will be damaged. Simple random biopsies will not work. You have to split open the testes, inspect the entire parenchyma under the microscope, looking for some area somewhere that may be healthy while most of the testes is damaged. What are side effects of microtesa? One, it's a long procedure. A full microtesa can take up to 3 hours. There may be some reduction in testicular size, some fall in testosterone, which may last for 3 to 12 months. So microtesa is an aggressive technique. It's a complex technique. It is a last resort, an act of desperation. So one important message for everybody watching is don't take microtesa lightly. If you're doing microtesa, your surgeon has to be willing to spend 3 hours, and your embryologist has to be willing to spend 3 to 5 hours hunting for sperm. These are not easy cases. You look for 10 minutes and find sperm. Those are cases where you'll find sperm in a random biopsy. So unless your center is committed to that much time, energy, effort, do not go in for microtesa.
Next is sperms. A couple have done the micro TC. The sperms were obtained and a good 8 embryos were there, but Dr. Bakshi has decided not to go for embryo transfer. She said that we'll do the FET because there was some risk of OHSS and maybe the endometrium was not in line, out of phase. So FET was planned in 2 subsequent cycles with adequate preparation of endometrium, and no success was there. So Dr. Bakshi, what may have been the reason? I mean, they had a good micro TC under hands of very experts, and you have done the FET. What could have been the reason for not being successful in FET with embryos fertilized with micro TC?
I don't see any particular reason in such a case, especially if you had good embryos, because these are rather naive sperms and they are not subjected to DNA fragmentation and anything. So if you do get good embryos, I feel that there should be pregnancy, because the 4 cases where I have had pregnancy, all 4 had twins. So where I could get a good sperm and good embryos, they all conceived. But I think this can be with, like in any case of IVF, this could be the cause that sometimes they do not get pregnant. But I'm not aware of anything particular. So if there is anything particular, I think my other panelists can throw light on that.
Anything anybody can think that what
Here
can
we have to exclude the aneuploidy also, madam. When it is not conceiving previous to frozen embryo transfer, we have to think of that embryo biopsy and exclude the aneuploidy problem.
As in any other case, means in any patient who is undergoing IVF FOGSI in whom good embryos are there, and if she is not conceiving, then you have to do the consider it.
Particularly micro TZ, madam, that you have to do. Like definitely here the incidence will be more, and also counseling also you should give. There is a, even if the patient conceives, there is a possibility it can be, if the baby is male baby, there is a chance that that baby also, that male child also can carry the same problem. That's also one thing you have to tell.
Yeah.
And here in this particular case, all the 8 embryos utilized, means some 2-3 transfers done.
Yeah, I mean they did 2 transfers. They did 2 transfers, and all 8 embryos utilized after APT. So really, I mean, Dr. Shah, suppose if they have not conceived, there was some reason which can happen in any IVF, not success. So can the couple go for micro TC, repeat micro TC, and how soon you can advise for repeat micro TC, and what is the success rate for repeat micro TC?
So first of all, when sperm were obtained, after the sperm were used for the first ICSI cycle, the remaining sperm must be frozen. In a man with testicular failure undergoing micro TC, the sperm are worth their weight in gold. You cannot discard any sperm. Motile, immotile doesn't matter. So they have had to be frozen. And actually there should be sperm available from the previous micro TC itself. Now, if there are no sperm available, usually one should repeat a micro TC only 1 year after the previous micro TC. But that actually depends on the first micro TC itself. How easily was sperm found? Did you find it initially within half an hour of exploring? Did you have to explore both the hemispheres? Did you have to explore both the sides? If the exploration was not very extensive and you found sperm quickly, then the repeat micro TISA will succeed even after 3 to 6 months. But if you've really had to hunt, and at the end of 3 hours found 5 sperm, and we've had cases like that, then you might not find sperm even on a repeat micro TISA.
So what are the complications which can be there with a long procedure which you would like to warn? As you have already said, this is a very, very super special procedure, should not be taken lightly. So is there any complications with micro TC you would like to,
if micro TC is not done correctly, it can result in significant devascularization and even atrophy of the testes, partial or complete. Infection, hematoma can also happen, and some degree of fibrosis with loss of testosterone levels. So micro TC done casually can be quite harmful.
Okay, thank you so much. Dr. Ramani, next we can just put the next slide here. And just before we go on to the next slide, are the embryos fertilized with sperms from micro TC or behave differently than the embryos fertilized with normal sperms? Are they behave differently?
There's a greater incidence of non-euploid embryos with testicular sperm.
Okay, then is there a place for PGD, sir, in these cases?
So it depends, because PGD adds enormously to the expense. So if it's a young couple where the eggs are likely to compensate for some degree, then the first cycle one would not bother. Also, it depends on number of embryos you have. Very often in a micro TC case, you may wind up only with 3-4 embryos, in which case doing a PGD is meaningless. You'll transfer all the embryos. But if you wound up with good number of eggs, enough sperm, large number of embryos, then a PGD would help you eliminate a fair number of embryos and thereby shorten the time to pregnancy.
I think anything anyone they would like to aid in this non-obstructive azoospermia, or Dr. Reddy or Dr. Kunjumuddin, anything else you would like to message, you would like to give in this particular?
In non-obstructive azoospermia, specifically, before sperm retrieval, like Dr. Rubinsha sir has told, there is no point for testicular diagnostic biopsies, only sperm retrieval techniques. And before this sperm retrieval techniques in non-obstructive azoospermias, we have to look for anything which can improve the sperm recovery rate. Like any hormonal issues or even varicocele can be corrected prior hand. Even if it won't bring the sperms into the semen sample, it can increase the sperm recovery rate. So that should be corrected properly before going for the sperm recovery procedures in non-obstructive azoospermias.
Dr. Bakshi, anything you would like to add into this case? Any message, a special message for, because it's a very common, report, and which people just immediately say, well, that's, like just the end, you cannot have any babies. So subtle ways, you have already said that you have to do subtle saying, and I think we should not disclose these reports over the phone also, because we don't know who is asking the reports from the other side. So it has to be always discussed, put on the table, and then talk over to the couple rather than just delivering it in their hand. You're muted, Dr. Bakshi, you're muted. You need to unmute yourself.
Now, one more thing here is many cases.
That when you do varicocele correction, even DNA fragmentation gets improved. So that is another indication for varicocele surgery. And one more thing I thought I should say, that if there is severe DNA fragmentation, then, and it is not improving with time, with antioxidants, with good lifestyle and everything, then in those patients also one can consider TISA.
Okay.
One more thing. So in this type of cases, there are some literature I have gone through. If you treat medically like HCG thing, even if there is, next is correction of the varicocele, even in bad cases also, these patients after giving 12 weeks or something like this HCG and other thing, so the recovery rate will be better with the micro-TZ. Dr. Rupin can explain if he has some experience on that.
Yeah, pre-micro-TZ hormone therapy is almost standard. It probably doesn't help in the majority of cases, but if you don't give it and you don't find sperm, the patient will go to the next person who will then blame you. So there's some science behind it. What you have to do is look at the testosterone level. If testosterone is over 400, then it means this testis is already adequately stimulated and there's no point in giving any hormone therapy. If the testosterone is below that, below 300, below 350, then maybe there is scope to stimulate this testis a little more. It's like whipping a tired horse, because these are men whose FSH-LH will be on the higher side and testosterone is low. But in such cases, if you stimulate further with HCG, CLOMIPHENE, HCG, HMG or aromatase inhibitors, FSH-LH will rise above normal, 1.5 times, 2 times above normal, and the testosterone will go up. And we hope that this rise in testosterone implies that the testis is functioning better, and maybe it will improve the chances of sperm retrieval. If you go through literature critically, there are several papers favoring this and several papers saying it doesn't help. But we do give it to patients following the criteria that I explained.
Suppose there is a varicocele there, will you operate the varicocele first, then you will go for the micro-TZ after giving some 3 to 6 months?
Yeah, very important, because see, the slide showed Doppler. Varicocele surgery may help in azoospermia only when it is a huge varicocele, something that anybody could pick up. So if on clinical examination the patient is normal, then doing a Doppler to pick up a subclinical varicocele is meaningless in any patient, and especially in an azoospermic patient. If a patient has a large varicocele and azoospermia, then if he's had a biopsy, that will guide you as to whether the varicocele surgery will help. If a man has Sertoli only or early maturation arrest, correcting the varicocele will not help. If he has a late maturation arrest or severe hypospermatogenesis, then correcting the varicocele may help. In a meta-analysis, 39% of azoospermic men, after correction of their varicocele, had the appearance of a few sperm in the ejaculate. The count still remains low. They still need ICSI, but the TISA could be avoided. And as was already mentioned, even after the varicocele surgery, if they remain azoospermic, there is a small increase in the sperm recovery rate by microTSA. So to answer your question, yes, if there's a large varicocele, then one can operate, wait 6 months, repeat the semen test, perhaps sperm may appear, and if not, then proceed for a microTSA.
Thank you very much, Dr. Shah. And I think just the key points which we wanted to bring out here from this case is, do not, subject the male to testicular biopsy just to differentiate between obstructive and non-obstructive azoospermia. There are other various means to do it. Micro-TC is an option in cases of non-obstructive azoospermia, but it is a highly specialized procedure, should be done with the specialists who are being very, very well trained in that, and counseling is a must. One question which I want to ask Dr. Rupin, Dr. Bakshi and all, suppose if a couple, since you're not doing a biopsy and you have done all investigation, you know that it is a non-obstructive azoospermia, you have taken the couple for micro-TC, the female partner's ovum are being picked up and you don't find any sperm on micro-TC, how you go ahead? Do you do a counseling for a donor sample beforehand, or what are your practices?
See, usually we counsel them that if we do not find, then are you ready for donor? And I've had patients, few patients were ready, but few patients were not ready. So in 2 of these patients, we have done oocyte freezing. And we have not repeated the micro-TSA in them, but we have done oocyte freezing, and they are still not ready for donor. So I think it's very important that beforehand you ask them what is their desire and then act accordingly.
There are 2 types of patients we'll get. One type patient, they are very particular, they want to use their sperms only, otherwise they don't want the IV FOGSI at all. In those patients, first we have to do and check whether it is there or not. If sperms are there, we can freeze it, then we can proceed with FOGSI later. Suppose other type of patient, they will say, we will try, if it is going to come like that, we can use your sperms. If it is not there, we have to go for the donor sperms. That time, even you can stimulate the patient. On the day of retrieval, you can try and you can take the sperms and you can use.
Dr.
And in my center, I generally want to encourage the patients for third-party reproduction. So they won't be ready for any sperm donor or oocyte donor or whatever it is. So generally we do micro-TSA, then freeze the sperms, then only stimulate the patient. We won't stimulate the patient and then do the micro-TSA.
That's also a good option. Dr. Rupin Shah, any comments?
Yeah, the problem with doing only a micro-TSA is that in 10 to 20% cases, the cryopreserved sperm will not be recovered. Because keep in mind, you're doing a micro-TSA in a very, very tough case. And once in a while, you'll have only 5, 10, 15 sperm. Now there's a new slide available for freezing rare sperm, but very few labs have the ability to freeze rare sperm. So if a patient is really desperate, doesn't want donor, you do his micro-TSA, you get 5 sperm, eggs are not ready, you freeze it, then you stimulate the wife, and when you thaw the sample, you don't find sperm, you've lost the only chance they had. So my counseling for patients is that if you want the best possible chance, you don't care about the money, you don't care about an unnecessary stimulation, then go in for a fresh cycle. If money matters, or if you're willing for donor, if you're willing for a donor, then also go in for a fresh cycle because you're having the best chance. But if money matters, you're going to take a loan for the IVF, then let us do the micro-TSA first, but be aware that there's a 10 to 20% chance possibility that the frozen sperm may not be recovered.
Many times oligospermia, when you freeze also, the recovery rate will be very less. So many times the no live sperms will be there. That's also have to keep in mind.
I think very
the newer sperm vitrification kits, sperm vitrification, that the thaw survival rate is much better than the conventional freezing.
So
like sir said, that sperm slides, which comes with sperm vitrification methods, the recovery rate is said to be much better.
I think we had a very good discussion on this case. I think very good inputs from all the panelists on, and I think many doubts must have been clarified, and routine questions which are being put up by a gynecologist and IVF specialist. So let's move on to the case 3. Over to you, Dr. Ramani.
Yeah, this was again a 29-year-old and 25-year-old couple who landed with a gynecologist with the fertility issues. Married since 3 years, coital history normal. Couple gave no history of hypertension or diabetes or asthma. Female partner had the normal cycles, no dysmenorrhea. There is no family history of fertility issues also. On examination of the female partner, on the 3rd day, everything was found to be normal, and she was having a normal uterus with a good antral count, basic blood routine and hormone assay, everything was normal, and she was advised for a tubal patency test on day 7. Okay, are we right in doing this procedure? First thing, without assessing the male partner, are we right in going in for all the evaluation, including the tubal factor?
No, nothing should be done for the female unless, say, that's why I'm telling like that. First, you should take the history, everything, the first couple itself, not single person. Then at least without single analysis of the semen analysis, we should not do any other invasive test or not minimal invasive or other test to the female partner.
Yes, because doing a semen analysis is a simple procedure rather than going in for a costly hormonal assay and all the other things. So evaluation of the male partner, he was well androgenized, normotensive, non-diabetic, teetotaler, manager in a pharma company, and no history of hydrocele hernia or previous surgery, no history of premature ejaculation or loss of libido. He was advised a basic blood routine. No clinical examination was done, and semen analysis was advised, and he was found to be azoospermic. How are you going to go ahead with this?
Yeah, here's the examination to be done.
This report, I won't accept this azoospermia like our things. We need complete semen report. Then only we can comment on that, madam.
Yes, sir.
Everything
so
should
the semen report.
Okay.
Volume of the semen was very low, 0.4 ml. No spermatozoa was seen even after centrifugation. Smell, musty odor, liquefaction time normal, color pearly white. Few round cells and leukocytes, and fructose negative. And what is the inference?
Okay. Clinical examination we have to do here, madam. How
Yes.
it is like he is otherwise normal. Testicular size also we have to see. If the testicular size, everything is normal, then we have to see it is whether it is normal size or smaller size, we have to see. If it is 0.4 ml means mostly it may be obstructive etiology.
Yes.
Then we have, depending upon the size of tested, we have to definitely go for the hormonal assay of this patient. Same way like FSH, LH, testosterone, estradiol, we have to do.
In this analysis to say that the probable cause could be obstructive.
Obstructive, because fructose also is negative here, and the volume is very low, 0.4 ml. That's
not just obstructive. When you see 0.4 ml, assuming that he's given a proper sample, 95% chance this is a case of vase aplasia, 5% it's a case of ejaculatory duct obstruction. So low volume fructose negative not only tells you it's obstructive, but it tells you where. If there's an epididymal obstruction, semen volume will still be normal. It's only when it's an ejaculatory duct obstruction or vasoplasia that the volume is so low. And vasoplasia is far, far more common than ejaculatory duct block.
Here actually that's what the fructose is negative and the volume also is low, like it is beyond the seminal vesicle, that is ejaculatory duct obstruction only mostly.
Okay, so that is what being fructose is a marker for seminal vesicle function, and it can be low or non-detectable in congenital absence of vas difference or seminal vesicle or ejaculatory duct obstruction. So clinical examination, what do you expect, sir, in this particular patient?
Was not felt. That was the expected obvious finding.
Yes, that bilateral absence of vas was a
Absence of vas.
Yeah. What are the further investigations would you like to do for this particular patient? Do you go in for an hormonal assay, or would you go in for a sonological investigation? What would you prefer, sir?
Actually, you don't need any investigation. You need the diagnosis of vasoplasia as a clinical diagnosis.
Yes.
The hormone profile will be normal. Scrotal ultrasound does not diagnose vasoplasia. Transrectal ultrasound will show absence of the seminal vesicle, but that's just confirmatory. It doesn't change the diagnosis. If the patient is opting for PSA, epididymal sperm aspiration and ICSI, then prior to that, we need to do a genetic test for the patient and his wife. If we cannot afford IVF ICSI, no further testing for the patient.
Yes. So the diagnosis was an obstructive azoospermia, and a patient has to be counseled for percutaneous epidermal sperm aspiration and rule out CTFTR gene mutation. I think you have covered everything. So here you have already mentioned the chances of sperm retrieval is going to be very high in your previous discussion with the previous case, and success of ART outcome is also going to be good. So something to add about the genetic evaluation, is there not, apart from this cystic fibrosis mutation gene testing, do you want any other genetic testing for this particular patient?
No, in fact, it's a good question, because very often I find IVF labs do a battery of all tests for all azoospermics. It has to be tailored. In
Yes.
Vase Plaza, it's only CFTR. You don't need karyotyping and YQ microdeletion. And in testicular failure, it's karyotype and YQ microdeletion. In testicular failure, you do not need CFTR testing. So that's important, because these are expensive tests.
Yes, sir. So is there any specific indication where you want to go for Y chromosome micro testing?
In non-obstructive azoospermia, and particularly men, we've seen that men who had YQ microdeletion, surprisingly, had fairly normal size testes, and sometimes normal FSH also. So azoospermia with a decent testicular size, but a collapsed epididymis, suggesting non-obstructive azoospermia, I would be more focused on a YQ microdeletion.
Okay.
Azoospermia with very small testes, there I'm more focused on karyotyping.
Okay, sir. So that's
Grossly, if you take, madam, just it is like this. Suppose if it is azoospermia, 13 to 15% of patients will be having the genetic problem. If it is votes, it will be around 5 to 7%. Even in normal persons also up to 1 to 2% will be there. If unexplained infertility there, you can subject this patient after discussing with them, if at all like that. This is the usually thing.
So the recommendations for genetic testing is what it has been given, that analysis should be offered to all men with damaged spermatogenesis when spermatozoa is less than 10 million. Testing for microdeletion is not necessary in men with obstructive azoospermia, and men with severely damaged spermatogenesis less than 5 million should be advised to undergo YQ microdeletion testing for both diagnostic and prognostic purpose. I think this has been explained. And here is a simple investigations. When you think about, when you have azoospermia, can you assess the site of abnormality based upon the clinical finding and the hormonal assay? That is, in congenital absence of where you can, it is usually a post-testicular event where you can have an absence of VAS, or it can be acquired VAS obstruction, can be because of these infections or vasectomy, and testicular size and FSH and testosterone will be invariably normal in post-testicular event. In testicular event, that can be a genetic cause or a radiotherapy, chemotherapy, or infection, and here invariably the testicular size will be atrophic, FSH level will be very high, and testosterone low. In non-obstructive azoospermia, because of hypothalamic or pituitary cause, it will be a small testicular size with a low FSH and low testosterone level. So I think we have discussed enough and everything about the testicular biopsy. And can you just freshen up, sir? Just give few points. When should you do testis biopsy and when you should not do testicular biopsy?
I've already mentioned my view. Maybe the other panelists would like to comment.
Dr. Reddy, sir, would you like to comment?
No, it is obstructive azoospermia. Usually, fine needle aspiration also will get, madam, for diagnostic purpose. At the same time, if you get sperms like that, you can freeze here. So if we are not getting like that, then you can go for the biopsy. Most of the time, you can get sperms here. So single biopsy itself, most of the times you can get here. As Dr. Rupin was telling like that, from depending upon the site of the things, we can go for the epididymal or testicular, anything you can do.
And here what we have to see in the biopsy, there is no question of a diagnostic biopsy, especially non-obstructive azoospermia. It should be sperm retrieval. It should be sperm retrieval. And like Sarah has already mentioned, we should discourage people doing just walking the testis too many times or mincing the testis with needle, which we very often see. That should be discouraged.
One more thing we have to keep in mind here, there is a maturation arrest, that problem, sertoli only syndrome also, everything will be like the same way, except here this problem is different, is vasal absence is here. If that is there, so that condition also we have to, clinically will be normal, all hormone tests also will be normal. There you need like this one to exclude whether it is obstructive or maturation problem or sertoli only syndrome, all things. That's also we have to keep it in mind. We have to tell the patient. Okay.
Counseling is very, very important here. So now the chances of retrieval of sperms in obstructive azoospermia, will it be different by each technique, and will it be depending upon the etiology?
Sorry, go ahead.
Anybody. Dr. Asha, would you like to take up this question?
With PISA, especially if it is bilateral absence of VAS, you really get very good sperm retrieval. But sometimes if it is higher up, then may be difficult, and then in that case you have to go in for TISA. So, but I think I'm not the best person to answer this question, so maybe you can ask this question to Dr. Rupin Shah.
So we always start with PISA because it is very non-invasive. And if we don't find on PISA, then we do a needle aspiration biopsy, not just a fine needle aspiration, but an actual biopsy. And the pregnancy rate, whether you have epididymal or testicular sperm, is the same. What happens in vasoplasia sometimes is the entire epididymis is atretic, and therefore you may not get sperm on PISA. And in infective obstruction, sometimes like tuberculosis, the entire epididymis may be damaged, and then PISA may fail. So we keep both options available. PISA is preferred because you'll get many, many more sperm, easier to pick up and easier to freeze for future cycles.
Okay, sir. Thank you, sir. So the success rate of each one is, it depends. That's according to the retrieval. The success rate somewhere it ranges between 15 to 50% in testicular sperm aspiration. In extraction, it is 20 to 60%. In micro-TSA, it is 40 to 67%. So if you are going to use sperm retrieval and do an ICSI in this patient, what will be the chances, whether when you compare obstructive and non-obstructive procedures, what will be the chances of retrieval, fertilization, conception and miscarriage rate? Which one will have the better outcome, non-obstructive or obstructive?
Obstructive will have a better outcome than non-obstructive azoospermia. And because aneuploidy will be there more in non-obstructive azoospermia, and chances of retrieval are also going to be less in non-obstructive azoospermia.
So these patients, they need a detailed counseling even before that. So the key points, what I would like to bring out from this particular one is, anybody can summarize? Reddy sir, can you summarize the key points in this particular case?
So identification of the site of obstruction is important. So that's why the management also will change. So like if it is like esophageal duct obstruction, transurethral resection of the esophageal duct will just, that itself is enough. Patient can conceive normally. Then after that, suppose vasal absence, then we have to go only for the sperm retrieval technique. Then we have to go for the ICSI only. Other things, suppose if it is vasal or epididymal obstruction, Dr. Rupin, are you doing the surgeries nowadays?
Yeah, we still do surgeries. Okay. We have patients whom the IVF people tell that don't go for surgery, it doesn't work, but they still come to us and they go home with a baby.
Okay.
Excellent.
What is the success rate? How is the thing?
So it all depends on how much of the blockage is there. So if, for example, we are planning a vasoepididymal anastomosis, and on examination, only half of the head is palpable, they will have a poor prognosis and we would recommend IVF to them.
Okay.
But if you get a nice head and a body which are turgid, then we'd have a 60% patency rate and a 30% pregnancy rate, which almost matches one IVF cycle.
And what is the success rate in VAS reversal, sir?
So VAS reversal, it depends upon the duration since the vasectomy and the location of the vasectomy. So longer the duration since vasectomy, secondary blocks develop in the epididymis, and then the success rate drops. If the vasectomy is on the convoluted vas, then technically it becomes quite complicated and success rate drops. But if someone has come within 2, 3, 4 years of a vasectomy, which was done on the straight vas, then the success rate would be 90 to 95%.
Thank you, sir. So I think I request Dr. Archana to take over the fourth case.
And we have very, very nice discussions and very extensive and intense discussion. So we'll quickly run through this case, case 4, where a couple of 33 and 28 consulted as a primary infertility, married for 4 years, and husband employed as a salesperson who travels a lot. There is no history of diabetes, hypertension, normal BMI, no smoking, no history of mom's chickenpox, no significant medical or surgical history for the male partner. The next slides, Dr. Ramani, can we have the next slide? I think, yeah. And if you look at the history of the female partner, she's a homemaker, attended menarche at age of 13, normotensive, non-diabetic, normal coital frequency, basic investigations for couple, female hormone assay were done on day 3, they were normal, and male semen analysis was advised, and couple were asked to review with the results. Next slide, please. The reports on the semen analysis. So what do we make out of this semen analysis report, Dr. FOGSI? I mean, the patient comes to you with this report of semen analysis. Semen volume 2.5, liquefaction count is 6 million per ml. So you look at the WHO criteria. So just tell me what are...
So the counts are less, 6 million. Motility is also less. And sperm morphology is also less. So basically it is a case of oligoasthenozoospermia.
So,
and
yeah. So next investigation, what you will advise, how would you counsel the couple? Because they were very upset after seeing the semen report, because they were again leading a very normal life, a normal sexual life, and no medical problems. So how would you do the counseling for this patient? And
I would like to repeat the semen sample once more, and at the same time do all the blood tests that we have discussed before, like to check for diabetes, hypothyroidism, to do the testosterone levels and estradiol levels. So, and just see and then recheck the thing. Okay, I didn't examine, and we should examine the patient as well and check if there is any problems. Because what happens usually, we don't examine and we send the patient to the urologist, andrologist. So yeah. So he has a varicocele.
Yeah, so Dr. Rupin, he comes to you, he has a varicocele, bilateral grade 2 or grade 3 varicocele. We wanted to bring in one surgical case also here. So that's what is it. So how are you really going to repeat semen sample, or how are you going to investigate them further and advise the treatment, Dr. Shah?
So a few things about varicocele. Remember that varicoceles are very common. And when a varicocele is present in a subfertile male, it may or may not be the cause of subfertility.
That's a good
About 60% of men with oligoasthenoteratospermia and clinical varicocele benefit from surgery, which means 40% don't. Given that fact, the way I would counsel this patient is, first I tell them, don't worry. You have sperm, which means one way or the other you'll have a baby. You have a varicocele, which may be the cause of the problem, and if we correct it, there's a decent chance, 60%, that you would improve. So we have two options. Either we can operate right away, or first we can try medically for a few months, and maybe the sperm count will improve, and if it doesn't, then we can do surgery, and then if it doesn't improve, we can do ART. So by counseling them in this manner, I'm creating a timeline and also making them understand that none of the treatments are guaranteed. Medical therapy is not guaranteed. Varicocele surgery doesn't guarantee an outcome, and maybe IVF might be required. With this counseling, majority of the patients actually say, Doc, we like to try medication. And there I would use CLOMIPHENE, usually based on the hormone picture, and antioxidants. So there is a role for medical therapy. And in my experience, roughly about 20-25% of men with varicocele achieve a natural pregnancy without varicocele surgery if the couple is young. If in 3 to 6 months they don't improve, then we would go in for surgery, giving them a average 60% prognosis. It depends on the starting sperm count. His count is only 6 million, so actually it's about a 50-50 chance that he would have significant improvement. Again, we would give them at least 6 months. We tell them if you are operating, wait at least 6 months. If by 6 months they don't improve and he remains the same, then you would go in for ART, and with a report like this, ART would be FOGSI, not IUI.
I think that's the roadmap for the plan of management, what you have given: medical management, then surgery, ART, and then maybe the combination of treatment. So next, I think you have already said about the surgery when it is indicated, when the semen report is abnormal, couples infertility is documented, and female infertility problems are curable. Next slide.
So just if you can go back, 2 important points to highlight in the previous slide. One, female has either is normally fertile or curable. So for example, if the wife has a tubal block and the male has varicocele, then the surgery is not compulsory. You could directly go in for IVF FOGSI using his sperm. And the second thing is point 1 says palpable varicocele, and that is important because since gynecologists don't examine patients, they do an ultrasound as a substitute for the examination, and that is very often misleading because if clinically there's no varicocele, then an ultrasound detected reflux is not of clinical relevance, and therefore an examination has to precede an ultrasound.
I think it's a very, very relevant point you have made here, Dr. Shah, that examination has to be combined with ultrasonography, or it has to be done before ultrasound. Only based on imaging technology, we cannot just subject the patient to a further treatment or make a concrete diagnosis.
Female partner's age also is important. One more.
Yeah.
Here it is only 25 years, what she has already mentioned, sir. Okay.
So 35% of subfertile men, lower sperm count and quality, lower sperm function, elevated oxidative stress levels, and elevated sperm DNA damage was found in cases of varicocele. Next. So varicocele treatment, I think we have surgeons on the list. They can tell us what exactly is the technique and what are the recurrence chances of varicocele, because invariably this question is raised. Okay, doctor, you are advising me to go for the varicocele surgery. Number 1, what are my chances of success, full outcome, and is going to recur varicocele? So how do you really talk to them, Dr. Shah?
So as this very nice slide shows, the lowest recurrence and the lowest complication rate in terms of hydrocele is when you do a microsurgical varicocelectomy. And the reason why microsurgery is good is also shown in the photograph, because with microsurgery, the artery can be identified and preserved, and every other vein can be ligated. So then the chance of recurrence is lower. Naked eye techniques or even laparoscopic techniques don't have that level of magnification and refinement, and therefore by other techniques, the recurrence rate is higher.
So I think this point also needs to be really taken into account, that surgery for even varicocele has to be done under the microscope, and it has to be done by the people who are expert in doing the varicocele surgery for infertility couple. So next, I think next slide, we can move on to the next thing. Management is already the options which we gave: medical management, then surgical management, and repeat semen analysis showed marginal improvement, 8 million per ml with 10 plus 10% of mobility. And what is your next advice on that, Dr. Reddy?
Here we can try IUA, madam, 2 cycles or 3 cycles. If she's not conceiving, then we have to go for the FOGSI, madam. That's only available.
So anything different in management? I mean, would any one of you would go earlier for ART before IUI? Does anybody defer here with Dr. Sanjeeva Reddy? We may not all be of the similar opinion. Someone might have some different thoughts and way of management.
It all depends on the patient's wish also. If the patient is not willing to wait, then you may have to give a fast track treatment like IVF.
Okay. So It is again the female evaluated and found normal, antagonist protocol followed, 8 eggs retrieved, 6 embryos obtained, pre-transferred, and singleton baby delivered vaginally. And subsequently, to her surprise, she had 2 natural conceptions. I think which is very common in IVF pregnancies, and she had husband had varicocele surgery, so maybe it is because of that they had a successful natural conception in this case. So next, I think the key message from this case, yeah.
So just a slide to show that varicocele surgery, how it can improve the spontaneous pregnancy, like how it has happened in our patient. And maybe the stress has been taken out. So that could be another reason why they have conceived spontaneously. And in treated, this slide, I feel it is very important because in treated varicocele compared to untreated varicocele, the incidence of fertilization, live birth rate is quite high, and miscarriage rate is quite low in treated varicocele. So probably like the sequence what you have, Dr. Rupin has explained, the history of, surgery followed by ART can give the better outcomes. So now the key points will be?
I think varicocele causes severe oligoasthenoteratozoospermia. It can be picked up by ultrasonography, but very important point which Dr. Shah has mentioned, that you really have to, subject for examination as well. And that can be managed medically and surgically. Not necessary that surgery is going to give us a guaranteed outcome. And IUI, ICSI will improve the outcome, and spontaneous conception is also possible after the varicocele treatment, may it be surgical or may it be medical. So next, I think with this, we really come to an end of a very interesting panel discussion. It was very, very interesting and really very good inputs, and I'm sure all the people, those who are logged in, must have got benefited. I think myself, I got enlightened and enriched by experience of all the experts on the panel, and thank you so much for sparing your time and being with us on this panel. And let me share with you one thing. Like before I was, we were planning for this panel, like how you approach, a couple of people that they say, well, male infertility, it's not that, it is boring. How really you can, how you can do a good panel discussion. And I must tell you, I really, really enjoyed this panel discussion, and it is really something which is serious problem, and it has to be taken very seriously. And what 2 things which I learned, my take home message from this panel is, even 2 simple examination, looking very, very carefully at the semen analysis, not only just the count or the motility, every detail of the semen analysis, and just maybe doing simple FSH and simple examination. You do not have to subject every male partner with a subnormal semen report to extensive investigation. That is my take home from this panel. Thank you very much.
Thank you.
Thank you, Dr. Archana, for having given me this opportunity to be a co-moderator on this particular male infertility thing. And I thank Dr. Rupin Shah, Dr. Sanjeev Reddy sir, Asha Bakshi, then Kunjumaidin for their excellent inputs. Like how Dr. Archana has said, that we had learned really, especially on micro-TC from Dr. Rupin Shah, and what the clinical aspect should be thought about from Dr. Sanjeev Reddy, and what is the significance of examination of the male partner. All those things are really small things, but they are really going to matter a lot in our regular day-to-day practice. And I thank all the panelists once again, and also the participants. Hope they would have been benefited by this excellent panel by none other than experts in this field of infertility. Thank you.
Thank you, Asha. And thank you, Kalyani, for being, conducting the whole program. And I would like to bring in here, just for a moment, Dr. Jayanta Jana from the Pharmet for really giving us good audiovisual support and good support and communication with all the panelists and all the speakers. Dr. Jana, would you like to come on?
I would just thank you, ma'am. Thanks a lot for this opportunity. And it's really a pleasure and honor to host you. And I would look forward to continue this kind of activities with you in future. And it's really a learning opportunity for us too. Thank you very much.
So thank you one and all. Thank you so much. Have a great evening and look forward for many more interaction with you all in the future. Thank you.
Thank you very much. Thank you very much, Archana, Ramani, and to all my co-panelists. It was really a very enlightening session and thoroughly enjoyed participating.
Thank you all. Thank you.
Thank you. Thank you.
Good night.